Hello, check. One, hello, check.
Good morning, everyone. We would like to start our sessions, starting with a free paper. I would like to invite our chairpersons, Dr. Adarsh, Dr. Sanjeev Kumar, Dr. Jitin Bajaj, and Dr. Vaibhav onto the stage, please.
Good morning, everyone. So we'll be starting the first session. Dr. Prateek Arora, please. Good morning, everyone. Respected Chair and members of the audience. At the outset, I'd like to thank the organizing team for giving me this opportunity to talk on this important topic, which is very clinically relevant, and I'm sure as clinicians, all of us come across. So the most common presenting complaint for any patient with brachial plexus injury is, of course, a loss of limb function and pain. In about 95% of the cases, the neuropathic pain persists in patients. Pain after brachial plexus injury is not only peripheral, it is central as well, and it is aptly termed as a mixed neuropathic pain syndrome. Pain begets pain, as we know. Untreated and unresolved pain often leads to chronic pain. And such individuals with brachial plexus injury often come with functional impairment, hindering their daily activities and reducing mobility. There happens a vicious cycle that once unresolved pain continues, the limb function will not improve and hence it will again cause pain. So a timely intervention for pain management can not only alleviate the discomfort, but also enhance functional abilities, promoting rehabilitation. The pathophysiology of pain after brachial plexus injury is really crucial in treating the pain. As we know, we have talked in past 2 days, we have seen various modes of nerve repairs, nerve transfers, but often we see that despite of beautiful sutures and surgical correction, the patient comes to the clinicians and say that my pain is not resolved. There is a certain feeling of not having the complete comfort. The reason is the pain post a brachial plexus injury repair is not as simple, and it is often the most difficult to treat. It is a nociceptive, a neuropathic. It also involves things like peripheral sensitization, central sensitization, and of course, there's a psychosocial component as well. So the goal of treating such pain should be to reduce the permanent disability, alleviate the symptoms, and restore or improve upper limb functions. The general measures taken to overcome such situations are physical therapy, in some cases acupuncture, and standardized electrical stimulation therapy. Pharmacological therapy, as we all know, we involve a variety of drugs, especially the anti-neuropathic medications such as pregabalin, nortriptyl, and gabapentin. Along with that, in a very big way, drugs like lignocaine, ketamine, acting on NMDR receptors, have come up in a big way in treating neuropathic pain. In addition to this, there has been an increase in minimally invasive pain and spine interventions, which primarily include stellate ganglion blocks, pulse radiofrequency ablations of the ganglion itself, and the brachial plexus. In addition, spinal cord stimulators, as well as peripheral nerve stimulators. So coming to one of the important modality, that is the stellate ganglion block. As we know, it is a relay center for all the sympathetically mediated fibers of the head and neck and the upper limb. It has found diverse indications in treatment of chronic pain of the upper limb, as well as vascular causes of the upper limb. As we know, stellate ganglia is a sympathetic ganglia located on either side of the neck, primarily formed by the inferior cervical ganglia, with the first and occasionally the second thoracic ganglia. Classically speaking, this was initially given as a landmark technique by palpating the C6 transverse process or the anterior chassignas tubercle. However, the location of the stellate ganglia is in front of the C7 vertebra. With the advent of fluoroscopy as well as ultrasound, it is now much more safer, precise, and a targeted lesioning of this ganglia can be done. Coming to what does the literature say about it, the proposed mechanism still remains debated. However, the stellate ganglia block modulates the nerve growth factors, which results in decreased sympathetic nerve sprouting and brain noradrenaline levels. And this has found application beyond brachial plexus injury in terms of sympathetically mediated pain, as well as post-traumatic stress disorders. The effect of stellate ganglion can not only help treat chronic pain, but it can also decrease the opioid consumption during the intraoperative period. Also coming to recent publication of pulsed radiofrequency ablation for the stellate ganglia, it has been shown that the reduction in release of substance P in response to a noxious stimuli can not only decrease the nociception, but also reduce hyperalgesia in patients with brachial plexus injury. Coming to the next modality of treatment, that is functional electrical stimulation. There can be various ways of doing it. Coming to the more important and the recent ones, the underlying mechanism or the pathophysiology is really important to understand for treating such pain. There is a cascade of neurotransmitters at the junction where the nerve has been transected. So the timing is really crucial of involving such modalities for treatment. The reconnection of axons and muscles accelerate nerve conduction speeds, enhances muscle fiber activity, and then restores the damaged nerve function. So one such modality is spinal cord stimulator. It has two components, a lead which is placed into the epidural space and a pulse generator which is implanted under the skin. This not only relieves, this is entirely based on the gate control theory, and by stimulation of A beta fibers reduces the pain symptoms. One such particular problem I'm sure all of you must have come across is the patient keeps on complaining of getting paresthesias. So we also have a relatively newer form of spinal cord stimulators, which are the higher frequency generators, which can also help in alleviating such symptoms. Coming to our experience with such cases, this lady came to us with the Pankos tumor leading to iatrogenic brachial plexus injury during lymph node dissection. And she was successfully treated with the conventional radiofrequency of the stellate ganglia, as well as the pulse radiofrequency of the brachial plexus directly. The patient is in remission and she is in follow-up with us for the past 8 months now and has her pain under control. The next case was for a panbrachial plexus injury, post-traumatic in a young male. This patient underwent spinal accessory to suprascapular nerve transfer. Patient absolutely did not have any motor functions at the beginning. He is still in recovery phase, it is early to say, but definitely his pain symptoms are much more controlled with the just even a diagnostic stellate ganglia block. So the take-home message is a multidisciplinary approach is certainly needed for such cases. And all patients are different. You have to have a tailored-based approach for such patients. Of course, the interventions are not readily available, but they have been proven time and again to have an effect for pain alleviation. Further scope of research in timing of these procedures is crucial and is, of course, open for debate. Thank you.
The forum is open for discussion. Any questions from the audience? I have one question.
Yes, sir.
how long you wait till you decide for an intervention?
Sir, it has been shown that interventions, when done early, are far better. Like we delve into the molecular basis, it is ultimately dependent on the calcium. So any stimulation that is done distal to the affected part of the brachial plexus, the calcium sensitization occurs. Once you nip it in the bud, it is easier. So like I said, there has been studies. If a stellate ganglion block, such a simple thing, done in the perioperative period while you're repairing the nerve, it will go a long way in controlling chronic pain.
What is the durability of these blocks?
So rather than terming them as just blocks, this is basically a relay center, the stellate ganglia. So the durability, as you say, I mean, there is no percentage wise to say that this is going to help you. It is very, very patient
I
centric.
mean, the length of the time for which it acts.
Okay, so this, like I said, is a vicious cycle. If you nip it in the bud and if you stop the pain signaling pathway then and there itself, it is going to have a long lasting effect. So timing is really crucial for such procedures. Thank you.
Thank you, Dr. Pratik, for a wonderful presentation. Now I will like to call Dr. Jalaj for his presentation.
Good morning to the faculty. Thank you for this opportunity. Much has been spoken about the usefulness of the musculocutaneous nerve, especially when we are utilizing it as a recipient nerve for rehabilitating or planning for elbow flexion surgeries following brachial plexus injury. I would briefly embark upon the anatomical variations that we encounter during these procedures. Intraoperatively, it can lead to a dilemma when we encounter these. And eventually, what we do on table will have a clinical implication on an impact upon the patient in the long run. So we came across 2 such cases in the past 3 years, 31 procedures which were done for restoring the elbow flexion following a brachial plexus injury, 25 ICN to MCN, and 6 Oberlin. And these were the representative cases. The first case was a 28-year-old male patient, post-traumatic right upper brachial plexus injury with only C5 and C6 root involvement, had MRC grade 4 of the C7 onwards. He had an initial right spinal accessory to suprascapular nerve transfer. And the surgery which was planned next for restoring elbow flexion was an Oberlin 1. But intraoperatively, what we found was that there was an absent musculocutaneous nerve. On exploration proximally, we in the arm, we found that there was a median nerve which was giving rise to a branch to the biceps. And eventually, what we ended up doing was we stimulated these. The biceps was not very well stimulable. The median nerve per se was causing a good flexion of the wrist and the digits on stimulation. And the ulnar nerve also showed stimulation, but it was not very good or not very powerful. Eventually, we resorted to using a median nerve fascicle to the FCR, which showed good contraction, and coapted it with the median nerve branch to the biceps. On a 1-year follow-up, the MRC continues to be grade 0 in the elbow. The second representative case was a post-traumatic pan-brachial plexus injury. An initial spinal accessory to suprascapular nerve transfer was done, and an intercostal nerve to musculocutaneous nerve transfer was planned. Intraoperatively, we came across this, a single cord-like structure, which upon exploration, we found on stimulation, we found that the musculocutaneous and the median nerve were both encased in a single epineural sheath. They were coalesced together. So upon some more further dissection and internal neurolysis, we were able to separate this. And eventually, we were able to proceed with a plan of intercostal to musculocutaneous nerve transfer. So going on to the evidence, there is mostly evidence based on the cadaveric studies, which show a high prevalence of anatomical variations of the musculocutaneous nerve amounting to almost 37%, and a systematic review which shows a 20% pool prevalence. The largest in vivo series was published in 2022 by Ganga Hospital, wherein they showed a prevalence of 11%. There is an embryological theory to the basis of why this happens. On the 5th week of gestation, as the upper limb bud organizes and forms, and all the spinal nerves penetrate this upper limb bud, they are under the effect of a lot of chemoattractants and chemorepulsants. And any alteration in their signaling, any alteration due to these factors can lead to abnormalities in the formation of the musculocutaneous nerve. And they are also responsible for the various connections between the median and the musculocutaneous nerve as encountered in these anomalies. The lay minor classification, which we all need to be aware of. Mainly, it has been classified into 5 types. The first type, in which there is no existing communication between the musculocutaneous and the median nerve. Type 2, in which the lateral cord contributes to the median nerve, but there'll be some proximal and distal communications between the MCN and the median nerve. Type 3, in which again the lateral cord contributes to the median nerve, but the communication between them will be much more distally in the arm. Type 4, in which the musculocutaneous nerve does not pierce the coracobrachialis at all. It tends to stay medial, and it tends to arise from the median nerve proper much distally in the arm. And a type 5, which is what we encountered in one of our cases, in which the median nerve and the musculocutaneous nerve are coalesced into a single nerve, a nerve trunk surrounded by an epineurial sheath. So in conclusion, I would just like to say that it is important to be aware of these anatomical variations, as intraoperatively they can pose a challenge, they can lead to a dilemma, and it can lead to a change in the intraoperative decisions. As encountered in our case, we had to resort to using FCR branch fascicle of the median nerve and coapt it with the biceps branch which was arising from the median nerve. The largest in vivo study which was described also suggests that whenever we don't come across the MCN in its usual location, it is imperative to explore proximally in the interval between the biceps and the coracobrachialis so that the anatomy is much more clearer. Thank you.
Thank you, Dr. Jalas. Any questions from the audience? I would like to know, you said that there are nearly 20% variation, anatomical variation. Can we note this pre-operatively by any means, by any investigation or clinical examination?
No, sir. I feel that it may not be possible to detect pre-operatively in any manner the location of, if there are any anatomical variations, it may not be possible to detect this pre-operatively. And that 20% is also a very high number that has been quoted only through cadaveric studies. The percentage falls down to much lower in only about 8% cases in the in vivo study. And the largest in vivo study which was described quotes only about 8 to 11% prevalence in vivo intraoperative findings in live subjects.
Hi. Nice presentation. I wanted to ask the case that you mentioned about FCR transfer, the median nerve fascicle was going into the biceps and that was not stimulable, you said, right?
Yes, yes,
And rest of the median nerve was stimulable.
yes.
Okay. And what was the post-op outcome? Like long term, you said it was 1 year outcome. So
Yeah.
what was the outcome?
So the outcome, the elbow flexion still continues to be MRC grade 0 after a 1 year follow-up.
Okay. So my question basically is that what do you think retrospectively might be the cause? That, see, technically coaptation must be right, everything must be right. You had stimulated the FCR branch as well. But if that branch going into the biceps, it was non-stimulable. So do you think that itself was the cause? Like leading to failure of the post-op outcome?
That could have been the cause, and at that point we had to make a decision to use what is the best possible available option. We found good stimulus on interoperative nerve stimulation. We found a good contraction of the FCR, and relatively
No, of the
towards
biceps, I mean.
of the biceps.
Yeah, like firstly, after how much time did you intervene?
So this was almost 7 months after the trauma had occurred.
Okay. And the status of the biceps when you explored for that given
Yeah, it
case?
was slightly hypertrophied. So that also could be one of the reasons why we didn't get a result 1 year down the line.
Thank you. Any further procedure that you did, like secondary procedures, did you do anything?
Not
for
yet.
that?
Not yet.
Okay.
It's still on a follow-up period.
Thank you.
Dr. Jalaj, I have a question. Normally, what we think is median nerve is a pronator, biceps is a supinator. So often we take a fascicle from the ulnar nerve and coapt it with the biceps branch. So why didn't you thought of this?
In this case, we found the ulnar nerve stimulation on intraoperative nerve stimulation was not very strong. And comparatively, when we stimulated the FCR, the contractions were found to be much stronger. And that is why we had to resort to use the FCR instead of using an ulnar nerve fascicle in this case.
Okay, thank you. So next we call upon Dr. Vikas Chaudhary.
वहाँ कर दो तो ये अच्छा
Good morning, everyone. Myself, Dr. Vikas Chaudhary, presenting trapezius, institutional experience of trapezius transfer for shoulder abduction in adult brachial plexus injuries. Talking about the introduction part, after severe brachial plexus injuries involving the shoulder, several secondary options are available, like rotational osteotomy, shoulder arthrodesis, muscle transfer, nerve transfer, or a combination of above-mentioned techniques. For restoration of movement and stability of shoulder, after paralysis of deltoid and supraspinatus muscle, different muscle transfers have been suggested, including transfer of trapezius, pectoralis major, teres major, latissimus dorsi, and combined biceps and triceps. In this study, we have analyzed the results of trapezius transfer for shoulder abduction after brachial plexus injury. We have operated 6 patients, 5 males and 1 female, by transfer of trapezius to proximal humerus. In 1 patient, C5, C6 roots were injured, and rest 5 patients had pen plexus injury. 5 patients had previously undergone nerve transfer surgery before going for trapezius muscle transfer. And surgery can be considered if patient presents with flail shoulder at more than 1 year after the accident without spontaneous recovery, or when it is clear that recovery following neurosurgical repair is not progressing anymore. A simple trapezius transfer is compatible with a later return of some function to other shoulder girdle muscles. Passive shoulder abduction of 80° is an important prerequisite for trapezius muscle transfer, and only contraindication is advanced degeneration of the shoulder. Talking about the surgical technique, patient is placed supine with a sandbag under the shoulder, or patient can be kept lateral, and neck, whole arm are painted, draped, and kept free. Could be better explained using the diagram. A Lasius incision is given as shown, and then trapezius muscle is marked, and elevation is started along with its insertions from the acromion, clavicle, spine of scapula, not disturbing the origin of the deltoid muscle. Deltoid fibers also. For orientation purpose, this is a video in which the patient is having right shoulder injury, and this is the lateral end on the forceps side. Trapezius has been elevated from its insertions, acromion, and posteriorly over the spine of scapula. You can see both of the things. And this is one of the postoperative result. Previously, overland procedure was also done, and patient is now able to feed himself by on his own right hand. This is the post of X-ray showing CC screws installed in the humerus part. So careful dissection is needed to define interval between trapezius and supraspinatus. Special attention is needed to preserve neurovascular bundle. Deltoid fibers are split longitudinally to expose proximal humerus, which is caught within osteotome. And postoperatively, arm is abducted to 100° and the acromioclavicular fragment with its trapezius insertion is fixed to humerus with 2 screws. Wound is thoroughly irrigated and skin is closed in 2 layers with shoulder splint applied in 100° of abduction. Postoperatively, drains are removed on second or third postoperative day as per the drain output. Spica is continued further at least for 6 weeks, and then night splintage is allowed, and physiotherapy has been started after 6 weeks. This is the case data, which we have operated 6 cases. Most of the patients had pain plexus injury and were between 20 and 30 years of age. Interval from trauma was mostly like after 1 year only they presented. And one patient we have a follow-up of 19 months. Rest of the patients are still in follow-up. In all 6 patients, an improvement of shoulder mobility and reduced multidirectional instability was seen. Shoulder abduction was measured as an angle between trunk and arm. As for the discussion part, fell shoulder secondary to brachial plexus injury is difficult to treat. After neurosurgical treatment and adequate physiotherapy, reconstructive surgery may be needed to improve the stability and function of the shoulder. Deltoid and supraspinatus paralysis may be managed by shoulder fusion, but it has several disadvantages. It is also irreversible and it has a high complication rate. Caulfield and Briggs pointed out that disadvantages of arthrodesis. There is incidence of fractures and 25% patients had no improvement and 15% patients had aggravation of pain. Trapezius, levator scapulae, rhomboid muscles, they remain healthy or recover in 96% cases and can be utilized for transposition. Mayer in 1927 described trapezius transfer technique for complete deltoid palsy. Bateman modified the Mayer's technique by osteomizing the spine of scapula near its base and transferring it laterally along with the trapezius muscle and anchoring the acromion directly to the humerus as far distally as possible with 2 or 3 screws. Saha modified Bateman's technique of trapezius transfer and improved the technique by dissecting superior middle trapezius is completely mobilized laterally from its origin, and thus transfer is made 5 centimeters longer without endangering its nerve or blood supply. In this technique, the entire insertion of trapezius along with attached lateral end of clavicle, acromioclavicular joint, acromion, and adjoining
The minimum and a maximum follow-up you had?
Sir, we had maximum follow-up of 19 months and patient is still in follow-up, and minimum follow-up is like 3 months, recently operated cases, which are still continuing physiotherapy and in follow-up, they are there. Thank you, sir.
Thank you, Dr. Vikas. We have we are now closing this section. Thank you. Thank you, everyone.
Any more speakers? Dr. Aparajita or Dr. Vaibhav, are they here? No. Thank you very much. Thank you.
I would like to thank our chairpersons for the session. We will now start our next session on adult brachial plexus injury. I would like to invite our chairpersons, Dr. B. Indra Devi ma'am, and our very own sir, Dr. Jiten Kumar Mishra sir. Please come and take the dais, ma'am. Please come and take the dais, sir.
A very good morning, delegates, and good morning to my co-chairperson. Our first presenter would be Dr. Sweta.
Very good morning, everyone. I'm Dr. Sweta. I'm a neurosurgeon at KIMS Hospital, Secunderabad. I work in a team with Dr. Manas Panigrahi. So recently we started doing peripheral nerve surgeries. So I want to present the initial work, what we have done, and maybe in future I'll present the further work. Thank you for giving me this opportunity. So starting with tumors of brachial and lumbar plexus regions, what we have dealt recently, I'm presenting today. So these tumors of these regions are relatively uncommon, and management is often a challenge to the neurosurgeon. So before going for the surgery of this lesion, proper understanding of the pathology of lesion and location of the lesion in relation to the plexus is essential. So intraoperative tools like ultrasound and nerve monitoring will help in the better localization and fine resection of the lesion with the nerve preservation. So coming to the pathology, peripheral nerve tumors can arise from the mesenchyma of the nerve or from the Schwann cells or from the perineural cells. So based on this origin, peripheral nerve tumors are divided into 4 types. Those who originate from the nerve sheath can be benign or malignant, like schwannomas, neurofibromas, and malignant peripheral nerve sheath tumors. And neuroblastomas, ganglioneuromas, and pheochromocytomas will originate from neural crust cells. And some non-neural origins tumors are like lipofibromatosis and neuronal lipoma and hemangioma and ganglion. And some traumatic neuroma and compressive neuroma are also there with the non-neoplastic origin. Fibromas. The basic difference between schwannoma and neurofibroma is schwannomas are generally encapsulated and we can remove it completely. And generally, fascicles of the nerve fibers are not completely involved in that. And even if fascicles are involved, generally single fascicle is involved in schwannoma and multiple are involved in neurofibroma. And in plexiform neurofibroma, obviously, the shape is deranged and many fascicles are there. We can't remove completely. And coming to the histological difference, there are no axons within the lesion in schwannoma, and axons and nerve fibers are seen throughout the lesion in neurofibroma. And S100 is strongly positive in schwannoma and it is weakly positive in neurofibroma. The surgical excision is also like complete excision is possible in schwannoma, but excision sacrificing the neural elements is there in neurofibroma. So diagnostic tools like MR neurography and intraoperative ultrasound are very much helpful in proper resecting the lesion. So we have recently operated 3 lumbar plexus lesions and 2 brachial plexus lesions. Till yesterday, everyone is talking about brachial plexus only. So I will start with lumbar plexus first. Coming to the basic anatomy of lumbar plexus are formed from the roots of L1 to L4. So at each neural foramina, as the nerve root comes out, it divides into posterior and anterior rami. And anterior rami of L1 to L4 nerve roots join to form lumbar plexus, and they give various nerves which pierce through the psoas muscle, and they lie anterior to the transverse process of lumbar vertebra and forms various nerves like ilioinguinal, iliohypogastric, femoral, genitofemoral, obturator nerve, and later form the sciatic nerve along with the sacral plexus. So this is the first case of lumbar plexus lesion. A 23-year-old male having low back pain with left radiculopathy since 3 years. There is no weakness, even though we advise surgery since the time of presentation. He was reluctant for surgery. Recently, his marriage is fixed, so he wanted to get rid of the lesion with the promise of no deficit. So we were trying to operate that. On CT, the lesion is extending through the neural foramina, and you can see the erosion of the vertebral body and some part of the facet also. So along with the help of surgical gastro, we have done this surgery with a retroperitoneal approach. The patient is positioned laterally, and through retroperitoneal approach, psoas is split, and with the help of nerve stimulator, the lesion is excised, like gross totally. Some part of the lesion was actually invading the nerve root, but we didn't touch that invasive part of the nerve root, because there should not be any deficit for that patient, as we promised. So whatever we can separate from the nerve, we have done almost gross total excision except the part invading the nerve. And interbody cage is also placed, as there is some body erosion, but there was no intra-op instability as such. The biopsy was neurofibroma. Patient did not have any deficit. So with this retroperitoneal approach, actually, it saves the time, and it gives the better access for the lumbar plexus lesions. The second case is a 53-year-old male with numbness of the great toe since 1 month and low backache on the right side since 1 week. But this 1 week he is having severe pain and he is unable to sleep. On examination, there is no deficit except some sensory loss over the great toe. So this patient has a sciatic notch schwannoma. The lesion is here in the sciatic notch. So as we can see, that is deep inside. So coming to the sciatic notch anatomy, a little bit light on that. The sacrospinous ligament will form the sciatic notch into a foramen, and the piriformis from the greater trochanter to the sacrum will divide the greater sciatic foramen into 2 parts. Generally, sciatic nerve will come from the inferior border of the piriformis, from anterior and inferior border of the piriformis. But there can be anatomical variations. One should be aware of it, because there can be a surprise when we open. So generally it is from anterior and inferior border, but sometimes the common peroneal component can pierce through the piriformis, and the rest of the component can be from the anterior-inferior part. And sometimes a part of the nerve is posterior to the piriformis and part is anterior to the piriformis. And sometimes whole of the nerve can pierce through the piriformis. And sometimes one part is posterior and one part is piercing. And sometimes whole of the nerve is posterior to the piriformis. So one should keep in mind these anatomical variations while excising the lesion. And the operative technique is, we have patient the position in prone position, and the incision is taken from the greater trochanter, and it is curved medially till the spinous process. And the gluteus maximus is split. Then we can see the sciatic nerve and piriformis. So in our case, this was like a normal variant only. It is coming from the anterior-inferiorly. So the piriformis is cut to reach the lesion, and The lesion was actually perioperatively soft and suckable cheesy material. Like total excision is done. Histopathology is schwannoma. Postoperatively, patient did not have any deficit. The third case is a 26-year-old lady with a history of left lower limb pain since 9 months and low back pain since 3 months, associated with tingling and numbness. But on examination, there is no deficit. There were multiple neurofibromas involving left sacral plexus and adherent to left ureter and iliac vessels. So, for which laparoscopic excision was done by our surgical gastroenterologist. We did not touch the part inside the nerve fibers. Just the decompression of the lesion is done because she was having pain and she was planning pregnancy also. So next, brachial plexus tumors. Actually, everybody was talking about all these things. I don't want to tell more, but we should understand the relation of the lesion with the brachial plexus. Whenever the lesion is from the roots or trunks, we generally go with supraclavicular approach. And then when the lesion is from the card, we'll go from infraclavicular approach. And when it is in between, generally we need to split the clavicle also. So this is the first case, a 58-year-old lady with a swelling over the right side of the neck, extending onto the shoulder since 20 years, gradually progressing in size with radiculopathy onto the same side. There is a recent onset weakness of shoulder abduction. She on examination, she was able to abduct till 90 degrees. Elbow power is 5/5 and wrist and hand grip are normal. So this is the scan showing the lesion from the nerves and trunks of the brachial plexus on the right side. So this is the lesion. So intraoperatively under nerve stimulation guidance, we have excised the lesion and the plexus are preserved, and histopathology is schwannoma. So postoperatively, she was able to lift the limb and there was no deficit. It is like same as a pre-op. This is the second case. Patient presented with difficulty in walking due to tightness of right lower limb and right hand grip weakness, along with numbness of right upper and lower limb since 3 months and paresthesias of left upper limb since 5 days. On examination, there was hand grip weakness and right hip, knee, and ankle 4+/5. DTRs were brisk and plantars were mute. There is a lesion in the spinal canal which is extending through the foramen into the paraspinal space on the right side. So we planned for 2-stage surgery. First is posterior approach with excision of intracanaliclar part, followed by in stage 2 anterior excision of the lesion. So in the first stage, we have done laminoplasty and excision of intracanaliclar part of the lesion. And this is the post-op scan after first surgery. The intracanaliclar part is gone and the part from the foramen extending to the anterior side is there. So we can see the lesion in the brachial plexus region. This is the ultrasound picture showing the lesion. So through the anterior approach, we have excised the lesion along with the fixation. ACDF is also done. This is the post-op pictures. There is no deficit. So we have done around total of 5 cases, 3 lumbar plexus and 2 brachial plexus. All the patients were fine, relieved of pain. Maybe numbness is present for a few weeks, but no postoperative deficit. So to conclude, one should understand the relation of plexus with the lesion, and tools like intraoperative ultrasound and nerve monitoring will help in better resection by preserving the nerve fibers and keeping the nerve intact, thus preventing the post-op deficits. Thank you. Thank you for my teacher, Dr. Manas Panigrahi, and thank you for giving this opportunity. Thank you.
Nice presentation and decent. Now I invite questions from Thank you.
Doctor, I have a question. Do you take prior FNACs before the surgery?
Not taking, sir. But for one case, we have taken with brachial plexus large lesion. So that was schwannoma.
Okay, thank you.
Now our next speaker is Dr. Damika. Dr. Damika here.
One thing more, how one is comfortable to operate when the patient is demanding 100% guarantee that you will not have any deficit? I mean, it is very difficult.
Obviously, you cannot guarantee. Thank
Good morning, everybody. So this is about adult closed brachial plexus injury, a conceptual presentation regarding multi-arm algorithmic approach for best possible functional outcomes. So what you will find is a cross-section of adult closed brachial plexus injury patterns and some observations on temporal relationships, the need for rational thinking in decision making, thoughts on finding solutions rather than alternatives or versus alternatives, and advantages of algorithmic approach in the management, thoughts on reliance on AI or artificial intelligence, as well as some thoughts on incorporating bioengineering on its various fronts. So as a result of the time restrictions, you won't see any of these in the presentation, such as details on investigations and surgical options and rehabilitation. So as I mentioned earlier, it's a conceptual presentation with the future in mind. So this is the cross-section. Neurologically speaking, as you all would know, it's neuropraxia and axonotmesis or a neurotmesis, or more often a mixed bag. And clinically speaking, it's a global or an upper or an extended upper or some of its variations. So after operating on brachial plexus cases for a long time, I still struggle to correlate, these two, the neurological aspect and the clinical aspect. So you may substitute this simple Sedon with Sunderland in its various modifications. However, still may not be able to, make much headway. And I think a better surgical classification is warranted for better understanding and decision making. So in this regard, a global registry of exploratory findings of the plexus and of the electrodiagnostic reports and maybe the MRI might help, to create a huge database on which AI can act. So we are like mostly in the center part of this Venn diagram as far as temporal relationships are concerned and the space and also the outcome. When it comes to rational thinking, doing no harm is of paramount importance. So as you can see, some of these procedures are inherently, maybe you call it unsafe unless an expert does it. And also now it has been a big debate, whether sensation is as important as motion in brachial plexus patients. As far as I am concerned, sensation is of great importance because limb that moves about, without being able to feel the surroundings, the environment, may not be as useful, to say the least. Yeah, so restoration of sensation, if at all possible, should be a must if you can. So neurolysis goes a long way. Now there was a debate about neurolysis. As I have found, neurolysis in every case of brachial plexus injury at the time of exploration is a must, because there are small twigs and bits and pieces surviving in the plexus in most of the cases. Now, except for total avulsions, you find some fibers crossing. So when you do a thorough decompression and neurolysis, a lot of them start conducting, especially sensory information. May not be good enough for motor, but for sensory, yes, I have seen again and again very good improvements in sensory after neurolysis. So also opportunistic sensory nerve transfers, whatever is available, maybe superficial radial nerve or maybe something else, that's why I call it opportunistic. And also provision of multiple motors. Now going to the branch level, as far as the recipient nerve is concerned, is the standard. But on the other hand, if you go to a more proximal level, like for example, trunk of the MCN rather than biceps branch, you have given more muscles, more motors to the limb to have natural or synergistic actions and more sustained action. Just one muscle may not be able to do the job. So, yeah. And early intervention. Now, there is no time limit for me. Even 1 day is okay. But it doesn't happen that way. Usually it is about 1 month by the time cases are, operated earliest. So that's a different story. But theoretically, at least as early as possible. So solutions versus, alternatives. Now, solutions aim at restoration and alternatives usually aim at substitution. So all the algorithms should ideally be aimed at solving the patient's problems rather than offering alternatives. So what are the minus points of algorithmic approach? Multiple algorithms are required to address the multiple clinical scenarios or settings, and multiple interactions exist between all of these. So I am sometimes, buried under my own algorithm. So that's why I want AI help. Combining multiple complex algorithms is an uphill task for a single surgeon or maybe even a group of surgeons. So what are the plus points? Because now this one comes from, I think, a movie, no one gets left behind, like a Stitch movie or something. So algorithmic approach ensures uniformity of treatment where everybody is offered something. You don't just not do any case, like you offer everybody something. So yeah. Yeah, it's a Pandora's box. So till you open, these are closed injuries. So till you open, you won't know. So to help in this regard, algorithms are very useful. Now this one is one of them. So I have broken this into like a number of algorithms. So this is a small part of it or a small algorithm. Now this is very well known. Now injury less than a month. If no, operate stat as soon as possible. No means it's more than a month. So you don't have to wait. No point waiting. If yes, wait till it's a month. Most people would say, in the meantime, you do therapy and so on. and, arrange for a list, that sort of thing. But now here I have confused you, like yes has 2 arms, wait till it's a month, and also I say operate stat. That's because of another algorithm like this. Now, if it's an axonotmesis or neurotmesis, well, this is incomplete algorithm. Purposely, I didn't fill the rest of it. So yes means operate stat. Now, even if it is, see now here, even if the injury is less than a month, if it's one of these, why should you wait? Now, another one. Injury more than a year. So no means less than a year, so you operate primary surgery. Yes, if it is more than a year, do not operate, most would say. But I would also say operate. Why? Because of this algorithm. Neuropraxia of more than 3 months, if the answer is no, you can initiate hand therapy. But if the answer is yes, you have to start operate, stat. Continue, or you can continue hand therapy. There are various options, so it's a bit confusing. So as I said, it's possible to start so many algorithms for each variable one. And it's impossible for anyone to incorporate all of them on one slide. That shows the complexity. Yeah, so I have included only a fraction of them. And here is the niche for AI or I complementing high. What is high? High versus high. So high is human intelligence. You can also call natural intelligence or NI. So the strong point about I is it's astronomically faster than high. So it's high time surgeons use I for the insane clock speed it has. Like I don't know how many times the human brain. In designing classifications and algorithms, and also in general decision making. And I is capable of, like very much capable of feasting on a large database of brachial plexus exploratory findings, investigative findings, etc., from all over the world. If it is possible at all to arrive at comprehensive classification types, and that will help clinicians plan individualized treatment for each of their patients. Individualized, not a normal algorithm that is generalized. This is individualized. So every time the surgeon doesn't have to think, if there is help from AI, it will do the hard part for you, for the surgeon. And that's because the algorithms are the lifeline of computer programs, deep learning programs, and so on. So it is the way that AI thinks, algorithmic way. So why not brachial plexus surgeons embrace AI for good? So in addition to that, small addendum, bioengineering, to be honest with ourselves, we are not doing best for at least, say, for the global BPI patients. We are not able to do, like give them fantastic outcome, wherever the world, it's suboptimal. So bioengineering and genetic engineering together with material sciences, nanotechnology and robotics. Now this robotics is operating, not about operating robots. This is, I'm talking about robotic parts, body parts. So something like robotic arm or a forearm or a hand that can incorporate, the advances in material sciences. So if you need a, like say, nerve conduit to provide sensation for the hand, that can conduct impulses from the fingers to a very proximal, uninjured nerve. So that kind of thing needs new materials, that's where the material sciences and nanotechnology come. So future algorithms, I hope, will offer robotics and nanotechnology their place that they deserve for the benefit of the mankind. So see you again. And let all be guided by light at the end of the tunnel. Any questions?
Questions from the audience?
Sir, I had put Chat GPT and asked it about algorithm in management of obstetric brachial plexus palsy or brachial plexus birth palsy. It didn't have any answers as such. So still probably AI is evolving.
And I think ChatGPT is evolving. ChatGPT is not the answer. You know, you have to first feed all the data. You know, have a global registry of everything and feed that to a special program. Now, ChatGPT is silly. You know, I asked one of my trainees to. He was not married, and I told him to ask ChatGPT. What kind of woman should I marry? It didn't give any answer. So there are things that
So, sir,
ChatGPT cannot do. A lot of things.
How to use AI in our sort of situations?
Yeah, no, I'm not telling that it can be done like this year or next year. I'm talking about a futuristic, situation. That's why I said it's a concept lecture, with this thing on in the future. The target is in the future. So maybe in 10 years it will happen.
Maybe.
Yeah.
Thank you.
Okay. Bye.
Thank you, sir. So next we call upon Dr. Chandni S. for her lecture on peripheral nerve sheath tumors, a diagnostic challenge.
Good morning, everyone. I would like to present a small case series of peripheral nerve sheath tumors that we have come across managing in our center. I work in Yenapoya Medical College, Mangalore, Karnataka. So just a brief introduction, as already one of the faculty here has discussed about the classifications and about nerve sheath tumors. They basically are neuroectodermal in origin. They can be, they are mostly benign, about on an average of 10% are malignant. They present with swelling, pain, or paresthesias along the course of the involved nerve. They can also present with sensory or motor deficits. I won't go in detail about the classification as it has already been discussed. Nerve sheath tumors basically are classified as benign and malignant. Benign tumors are mostly schwannomas, which are the majority. There can also be neurofibromas. The malignant counterpart is malignant nerve sheath tumors. These are basically diagnosed based on clinical presentation, where patient presents with pain mostly as the first symptom, followed by noticing the swelling in the region. Patient can also present with weakness of that particular limb or with tingling and numbness in the region. On examination, there can be a positive Hoffman-Tinel sign on tapping the swelling or the tumor in the course of the nerve. They are mainly imaged by MRI. So in MRI, we can typically delineate the tumor, the extent, and the adjacent structures that it is compressing. So MRI is difficult. It is difficult to say whether the tumor is benign or malignant based on the MRI. There are some reports of FDP PET scan which say that there is more uptake in case of malignant nerve sheath tumors. So in case of clinical suspicion of malignancy, we can go for a PET scan, which is not routinely done. If the patient has rapidly progressive symptoms of pain or rapid increase in size of the swelling with the skin changes overlaying it and severe neurological deficits, only then we go for a PET scan. It is not routinely done. We treated 6 cases between 2015 and 22. Detailed history, as already mentioned, and clinical examination was done. Tinel sign was positive in most cases. Investigation, we did an MRI. In only one of the cases, an FNAC was done preoperatively. Treatment was surgical in all cases. Complete excision with loop magnification was done. Re-examination in the post-op period as well as follow-up was done. The first case was a 32-year-old man. He was a transplant program coordinator. He presented with a swelling over the lateral aspect of the left ring finger. He had pain on and off in the region of the swelling. However, due to severe trauma, trivial trauma also, he used to have excruciating pain. On examination, there was a subcutaneous swelling of 0.5 by 0.5 centimeters on the radial aspect of the left ring finger. It was non-tender on examination, and mobility was restricted along the direction. The nerve Tinel sign was positive on the swelling. On MRI, there was a well-defined lesion in close proximity to the radial digital neurovascular bundle without any invasion of the nerve. So that was the intro picture. The tumor was in very close proximity to the digital nerve, but it could be easily separated. In a lot of cases, it may not be attached to the nerve from which it has arisen. So the biopsy came as schwannoma. There was no deficit after surgery. Wound healed well and patient was free of symptoms. The second patient was a 46-year-old woman who presented with pain in the right hand since 2 years and swelling in the neck since 6 months. The pain was dull aching with paroxysms of shooting type of pain on and off. There was no weakness in the limb. On examination, there was a ill-defined swelling in the posterior triangle of the neck in the lower third. It was a 3 by 3 centimeter swelling, which is non-tender. The mobility was restricted in the longitudinal direction. Tinel sign again was positive on the swelling. There was no sensory or motor deficit. MRI showed a 3 by 3 centimeter well-defined lesion, which was involving the C5, C6, in between the C5, C6 nerve roots. It was closely adherent to the, in close approximation to the nerves. On NCS, there was no deficit. The tumor was excised under GA. Intraoperative nerve stimulator was used. The tumor was between C5 and C6 nerve roots. All the nerves was preserved. So that is a tumor and the upper trunk seen. The tumor was excised completely, preserving all the nerves. There were no deficits postoperatively. Patient symptoms subsided after surgery. The biopsy came again as schwannoma. So I don't have a video of the patient. Patient has almost complete range of shoulder abduction postoperatively. Third patient was a 23-year-old man working in a supermarket. He complained of difficulty in holding and lifting heavy objects with the right hand since 1 year. The swelling on the medial aspect of the right arm since 8 months. The swelling was 1 by 1.5 centimeters in the anteromedial aspect of the right arm in the lower third. It was non-tender, mobile in the transverse direction. Tinel sign was again positive. The grip strength in the limb was in the right hand was reduced. No other deficits were seen. The MRI showed a well-defined lesion in the right arm involving the median nerve. NCS showed median mononeuropathy. The tumor was excised under brachial block. Tumor was within the nerve. It was removed by interneural dissection. Nerve stimulator was again used, and there were no further deficits postoperatively. Biopsy showed a schwannoma. There was improvement of grip strength. There was no, it would not be assessed due to the loss of follow-up of the patient. Here we can see the tumor and the median nerve. It was excised by preserving all the nerve fibers. My fourth patient was a 65-year-old woman who presented with pain in the left lower limb since 4 years, swelling in the posterior aspect of the thigh since 2 years. The pain used to aggravate while squatting. There was no history of any weakness in the limb. The swelling was detected by a doctor 2 years ago. It gradually increased in size since then. Deep-seated swelling in the submuscular plane in the upper part of the thigh on the posterior aspect was seen. It was about 10 by 6 centimeter in size with restricted mobility. Tinel sign was positive on the swelling. There was no distal deficit neurologically. MRI showed a well-defined tumor of 10 by 6 centimeter size on the posterior aspect of the sciatic nerve. The FNAC was done in this case, showed a nerve sheath tumor. NCS showed no abnormalities. The tumor was excised with the patient in prone position. Nerve locator was used intraoperatively. All the branches were preserved. There was no deficit postoperatively. The biopsy showed a borderline malignant nerve sheath tumor. So the patient underwent local radiotherapy. That is a photo showing the tumor. The peroneal as well as the tibial components are marked. Now the branches were preserved by intraneural dissection and a magnification. So that is a tumor. The fifth patient was a 17-year-old girl who came with complaints of pain in the anterior aspect of the knee and swelling in the anteromedial aspect of the thigh since 1 year. There was a barely palpable swelling in the medial aspect of the thigh in the distal third. There was tenderness present of the swelling. Tinel sign was again positive. The MRI showed a well-defined lesion of 1 by 1 centimeter size in the subcutaneous plane. The tumor was excised under local anesthesia. One of the fascicles of the nerve was cut during the procedure. The end-to-end neurorephy was done. Patient was completely relieved of her pain. The biopsy again showed a schwannoma. So this is the lesion. It was excised completely. I mean, one nerve was cut, it was repaired, one nerve fiber. Coming to the sixth case, it was a 26-year-old male patient. He complained of swelling in the upper lip since 6 months. He didn't have any pain. It was purely cosmetic reason that he had come. Painless, gradually progressive swelling. Clinically, it appeared as a lipoma on excision biopsy under local anesthesia. Histopathology showed a neurofibroma. It had a fatty appearance. We almost thought it's a lipoma. The histopathology showed a neurofibroma. I'd like to mention another patient. It's not exactly a nerve sheath tumor. A 40-year-old female patient who presented with weakness of the finger and thumb extension since 5 months. The swelling was noticed on the back of the forearm since 3 months. The MRI showed, as a dimension mentioned, a solid lesion in the supinator muscle, and it was suggestive of lipoma. But clinically, we almost thought it would be a nerve sheath tumor because it was in close proximity to the, even in the, I don't have the MRI images, in proximity to the posterior interosseous nerve. So intraoperatively, we found that there was a stretching of the PIN. On histopathology, it was confirmed as per the MRI that it was a lipoma. So this was a lesion. The patient actually presented with thumb and finger drop, and it was completely excised. We could not assess because she was lost on follow-up. At 1 month, she still showed features of palsy. So these are the demographic details. So the symptom on an average was a pain of about 18 months duration. The swelling was noticed much later, around 10 months. Most patients had prior consultation from a primary care physician. So there was a significant delay before the patient was either referred or the patient came to the tertiary center. 5 of the subjects had Tinel sign positive. And in 5 subjects, 4 of the 5 subjects, there was pain relief after the procedure. So I'd like to conclude that there is a significant delay in the onset of symptoms, as I already mentioned and the patient receiving the appropriate treatment, there is a lack of knowledge among the other medical professionals regarding feasibility of the surgery. So a lot of people dissuade patients because they fear that they may have neurological deficits following the surgery. So most tumors can be excised without significant functional deficits. Large tumors can be malignant. We have to mark the tumor field with hemoclips to facilitate radiotherapy postoperatively in case there is a need. We should always plan for nerve grafting, take appropriate consent in case we are not able to preserve all the fibers. Use of intraoperatively nerve stimulators help in identifying and protecting and preserving the nerve fascicles. And for that, we need to use plain adrenaline solution for hemostasis. Yeah, thank you.
Thank you very much. The house is open for questions. So I have two questions. First is, after how much sacrifice of nerve fascicles you consider reconstruction using a graft? And second question is, you mentioned one of your thigh tumor was operated under spinal anesthesia. So how reliable is the motor stimulation under spinal anesthesia?
Sir, there we were able to completely excise the tumor, sir. So because of other anesthesia, general condition of the patient, we could not take it up under GA. So in that case, we are not able to use the nerve stimulator. It was in the sciatic nerve, and basically it was a case referred from, meaning we were called intraoperatively by the oncosurgeons. So it was not exactly, we were not involved in the pre-op planning as such. So because they saw that it was so much stuck to the nerve and were not able to dissect it out, that we intervened. So, but I have just included it in my CV.
Okay, okay. And after how much sacrifice of nerve fascicles do you consider reconstruction using cable graft?
How much meaning, sir?
I mean, suppose you have to sacrifice, the tumor is involved in nerve so much, you have to take out some of the fascicles to excise it completely, or you find some of the fascicles have got out with the tumor. So after how much, what is the threshold for reconstruction of the nerve using grafts?
You mean the distance?
The percentage of fascicles. Thank you. Thank you.
Yeah, I thank to all our speakers, and now we conclude this session.
Thank you.
Thank you very much, sir. We would all take a short break for tea now. Thank you.
Good afternoon. My name is Mariano Sokolowski, and I will
वो में स्टार्ट ये टारगेट लगा रही उस वाले तो नहीं हो सकते। अच्छा तो कपड़ा ला तू यार कपड़े में एक नंबर लगा दबाया इसको भी ठंड लग रही है। बाहर कैसे निकलना? हेलो, पॉइंटर का है, पॉइंटर। अच्छा, इस पे काम नहीं करता है तो यहीं से ही करना पड़ेगा, यहीं से करना। ओके, ठीक है, यहीं से करना। दैट्स फाइन। इससे
Good morning, everyone. We will be starting our sessions now. So our next session will be Expanding Peripheral Nerve Universe. For this session, I would like to call upon Dr. Kishore Jha, Dr. Gurpal Chabra, and Dr. M.S. Gopalakrishnan to please take the dais.
Hello. Good morning, everyone. Now I call Dr. A.K. Purohit to deliver his lecture. Dr. A.K. Purohit. Role of selective motor fasciculotomy to control non-progressive localized dystonia.
Good morning to each and every one of you. Appreciate the presence of really interested audience in the particular subject today, the plenary session, Expanding Peripheral Nerve Universe. That's a great idea. And naturally, the less attention has been paid on the peripheral nerves, especially when it is not a traumatic condition. And I will be presenting you to the non-traumatic or a traumatic sequelae related to the central nervous system. And these are either the spasticity or dystonia. So what are we going to discuss today is the hyperactivity of the muscular system because of the damage to the nervous system, and that is the central nervous system. When it can produce two kinds of the hypertonicity, one is in spasticity and another is the dystonia. So we will be discussing today more on the dystonia because that is much more challenging than the spasticity, the work which we started in 1988 on spasticity, and gradually we tried to move towards the not only spasticity, but how the challenging dystonia can be treated. Much more interesting part was that initially when we started doing the surgeries for the spasticity, some of the patients were diagnosed by some other physicians or the surgeons as spasticity and or dystonia, and they directly bombard on the muscle, and we found that they had a very painful condition following the surgery directly on the muscle without reducing what is called as the hyper impulse transmission to the muscles. So today we will be talking more on the localized part, where we will be dealing with the peripheral nerve, how they can solve to some extent, control to some extent the dystonia. Means a peripheral solution for the central problem, as yesterday very nicely on a vagal nerve also somebody talked about it. Just for in a brief, I would just like to mention that the damage to the central nervous system or to in the spinal cord or the brain, we have various kinds of the procedures. These are the non-ablative procedures, and others are the ablative procedures, which either works on this particular reflex arch, that is the monosynaptic spinal reflex arch, on which only we are really right now bombarding, because there is an excessive bombardment from the anterior horn cells or from multisynaptic pathway in the dystonia. We would be taking mainly today about the selective motor fasciculotomy. I have coined this word of fasciculotomy so that the mindset of the surgeon goes on the vesicle, not on the nerve, that neurectomy or neurotomy. No, it should now divert our mind to the vesiculotomy. 1998, Acta Neurochirurgica, we coined this word and it was accepted. So a botulinum toxin is the another possibility. Soft tissue release is another. So this is how at the periphery we will be working to see how best we can control dystonia. So these are the non-ablative procedure. And these are again the rhizotomy with which we started in 1988, our journey. And then 1993, first time selective motor vesiculotomy. And yes, we do combine with the, as and when indicated on the soft tissues also. So this is all of you are aware, musculocutaneous nerve, like a corduroy, how they are vesicles, and then how you select, and from each one of them, how you ablate is the one which we are going to talk about. So there are various generalized dystonia. This is segmental dystonia. This is again a diffuse one. He has to hold his abnormal hand with the normal hand. That is the another problem with the focal or localized dystonia, that they are so much disturbing, like an naughty boy in the class to whom the normal boys have to control. So the normal one are also engaged, and that is how the problem occurs, that you have, if you can control dystonia of this hand, yeah, this is again free. Even if it is, you are not able to bring some functions here, but you are able to make this limb free to work well. These are the various age groups in which we have to work, that initially always therapies or physiotherapy, orthotic, then always non-ablative procedures. And then with the advancing age, you go for the other neurosurgical procedures. Later comes orthoplastic and neuro when they are grown a little much more from the 8 years onwards. But always there is, from the beginning to the end, up to the 20 years, yes, they may require sometimes some kind of an procedure, non-invasive or invasive, depends. Now, as far as surgery is concerned, we call it as a Brahmastra. It should be used at the end when it is refractory. 3 presidents went to Lord Brahma and asked Lord Brahma, let me know when the economic condition of my country will improve. When American president asked, Lord Brahma said, not in your regime. Why, sir? It will take long time and you will not be president till that. Then the Russian president asked Lord Brahma, let me know when the economic condition of my country will rise. Lord Brahma said, not in your regime. It will take long time and you will not be president. And when Indian president asked, let me know when the economic condition of India will improve, Lord Brahma said, not in my regime. I'm happy that today this joke is outdated, that the country is doing very good and that we should be proud of it. But the moral or the lesson from this particular incident or joke, you can say, is Brahmastra should be used at the end when no other methods can help you. But do not delay the use of this Brahmastra. That is another very important thing, because these patients do develop contractures, dislocations, and whatnot while waiting for the Brahmastra to be used. So it is very important in life that you know how to use which weapon at what time. So these ablative neurosurgical procedures are like Brahmastra, but before that, if required, you can go for the non-ablative procedures. I will not go into detail of the, this is the median nerve. Then this is about the rhizotomy, that how we position cauda equina and on the table. For a diffuse spasticity, I'm talking about. But then for such a diffuse spasticity, rhizotomy in cases of dystonia is not indicated. Please remember, dystonia, no rhizotomy. I will show you somebody did and then problems occur. So these are some procedure which vesicle has been lifted up for the pronator, and then we clip it, cut, and then clip and cauterize. This is the nutshell, in a short, I'm just trying to explain you that how the fasciculotomy is done. The fascicle which is being diagnosed or localized at that time, that this is the particular dystonia or spastic muscle we have to ablate, and that is what is being cauterized. Electrocautery, how it is to be done is very important. If you do too much, the stump fall. If you do too less, it grows. So we will have sometimes how I do in that the more details of the surgical procedure. So this is how pre-surgical, and this is how his ADL improved. This is spasticity where we started our work long ago. This is again too late, the contractures and the some dystonia, lot of spasticity. Again, she has to control her limb by this one. So we did the multiple fasciculotomy and soft tissue release, and this is how her hand has become free now, and she can use this normal hand well after this. So as we were talking about algorithms, so here there will be a small algorithm, as very rightly said, that ultimately you have to individualize, you have to customize. But this is a guideline, a path on which you have to think of, and then you have to go for. I will not go into much detail of it, but this is the focal or segmental or localized one. Then how we go for the, after some of the non-ablative procedures, we go for the selective motor fasciculotomy if this does not improve. But please remember, in a generalized dystonia, you have to go for the intrathecal baclofen. That is the wonderful results with that one. And some people cannot afford, or it is not possible because of various reasons. Then you have to go on the body and see which is the most harmful dystonia, and that one you can do selective motor fasciculotomy of that one, short of, if cannot be done, intrathecal baclofen, which is 8 lakh rupees pump. This is the another boy from the Gulf country, and you can see here the challenge our this particular dystonic surgery is that the things keep changing. So here you can find that there is most of the time there is an extension and there is an fisting. So we have to do repeatedly, we have to see the various times videos in the home and the places where they are relaxed, they are tensed, and then you have to see which is the consistent most harmful dystonia and how are the antagonists of it. Based on that, you have to decide that how much, which muscles, fascicles you have to. So this is how after the surgery, this limb has, he is able to abduct also. And it has come into, this is what is the, he was not able to lift like this, so he's trying to show it. So this was the extension of the wrist, and then he is able to hold this. They only have happy with this. So what I want to say is that it is not that easy to just see once and you think that, yes, this is, no. Repeatedly, various situations, videos, you have to see. Now, this girl came to me, and then her, you can see that severe fisting and some elbow flexion and some pronation. So then we did the surgery, and mainly this fisting, which was immediately after surgery, you can see that she is able to immediately open up the, and then we ask about some of the questions which then she went for a bangles as any girl will like, and she was able to pick up in this particular hand and wear this one. And she was not able to open, but now she is doing the nail polishing. Any girl will love to do these things, and we are able to provide them what they like it. And then she sent me the video that how she can hold it and then jump both the things, because we did at that time the equinus release also by the tibial nerve. And then ultimately I realized why they have come at this age, because mother wanted her to get married. Now this is after marriage, that this extension, we did relieve her equinus, but this is giving some tension and some fisting, residual one. So then we did common peroneal nerve surgery and we relieved the extension of the great toe. So this is the just what we were showing to you about the finger flexion And lot many things we have to do here during this time and decide that which one we are going to, how many fascicles we are going to ablate so that the extensor, the antagonist do not become hyperactive. But it does happen, and you have to explain to them that that is the problem. Then next time we may have. Another big problem is even to cut the nails is difficult for these people. And they injure themselves through the index fingernail. She injured herself. This girl I have done long ago, the equinus release when I was in Nizam's Institute. And now when I was out Nizam's, they came again for this particular thing. Then this improved after we did earlier some dressing, and then we realized that no, we have to relieve it, and then we released. And then her ability of not disturbing, she was able to. We'll show you some more videos of it. So this is what she was having a lot of problem with the segment. She has a diffuse one, but this particular limb was maximally affected and she was not able to perform. So we then operated. This is the peroperatively. Again, you see the finger are in flexion, means they were consistently. This is another important thing. Without muscle relaxant under general anesthesia, you can find that what are the consistently causing the contraction of a particular muscle. So we go to the next one. We have a few more videos of it. So on the table, this is then we perform various finger flexion and sorry. And here, you should not be too much stimulating. Otherwise, what happens? That they go into fatigue also. Then your results may not be. So make sure that, so this is the finger flexion and this is the pronation you can see on the table. And you can see the wrist flexion. So this is how it takes a little long time with or without microscope. You have to look into all these matters. So this is how they have, she has improved her this thing and how the family is happy immediately after that. This one is not disturbing her more active hand. This is another one. Somebody did rhizotomy for his segmental dystonia in one of the private hospital. Then he came to me and in Jupiter Hospital, Mumbai, there we performed the surgery. And he is very happy. He sent the email that how now he is able to apply even the prosthetic orthotic devices to it and how they have improved just by this skin crease incision. That is the this is very interesting and we are still working on it. This boy man went to one of the very good center and he has a protraction. So long thoracic nerve of Bell was cut and then he developed a lot of retraction. And then we are in shoulder retraction and upward movement of the shoulder. And he's showing his normal one and how he showed some improvement following our first surgeries on the trapezius muscle. And still we worked on the dorsal scapular nerve also and did some of the ablation and nerve block, nerve marking, so many things go on. And this is the retraction. So this is the shoulder dyskinesia. Very important to diagnose that it is a dyskinesia, not an spasticity. And if you relieve one antagonistic become very strong and there is a lot of trouble. He has improved tremendously. There is an incision. I have done very little of the ablation of the dorsal scapular nerve. we are again going and ablating little more. So a lot of staging will be required in these cases. So what I want to conclude that the selective motor fasciculotomy, you may call it selective neurotomy, some people may call it hyperselective, whatever the wordings, we can discuss sometimes what is the correct wording should be, is good for the localized spasticity and dystonia. When you remove these hyperkinetic things, then residual motor function become evident to you, and it may or may not improve the functions. Then the passive range of movement improves and it is easy to move it, so contractures can be prevented. Yes, the cosmetic, I have lot many stories that how cosmetic purpose is also for one of the indication. It is very safe. I don't find any, if you have done sensory nerves you have protected, you are as close to the myoneural junction as possible. Where there is a natural dissection of the fascicles, you will find that you are not going to cause any kind of a damage. So extremely safe, no recurrence. Some of the things which you see immediate post-op, say in that dystonia in that girl's hand, is a neuropraxic effect also. So after few weeks to few months, you really know what is the result. Hardly any wound complication. And I usually give to these patients gabapentin pre-operatively and post-operatively for good health of the nerves, myelin, no recurrence. So this is what in 1992 in Japan for rhizotomy, where we started our journey. Then in Florida, Gainesville with Dr. Jogi Pattisapu's office. And then we believed in, and we believe too, that the country requires the camps to select and then plan the management. This is somewhere in Tamil Nadu. And a neuro-ortho approach is a must. Lot of things which the orthopedicians will know about the muscles and the bones, which that much a neurosurgeon will not know. But as much as the neurosurgeon knows about the nerves and nervous system, and the clinical examination also will not be known that much to the orthopedician. So the two brains, if combined, and also the physiotherapy, occupational therapist, and the orthotic people, naturally, the neurologist is required, the pediatric neurologist is required. So that all make a big team. I'm talking only about the surgical team in the operation theater, but before, outside the operation theater, this is in Jupiter Hospital where I go somewhere and perform some surgery. So this is our neuro-ortho with Dr. Taral's team in Jupiter Hospital, Mumbai. This all, we did the cadaveric dissections, and then now, most important thing which at the end I would like to mention is professionals are biased with what they know. And the families are confused as to what is best for them. Please join hands, and such conferences are great things for us to join each other, understand each other, and make the team have the cross-referral and finally give rise. When they go to the individuals, whether they go to a homeopath or they go to an orthotic or a physiotherapist or occupational therapist, everybody says, मैं 1-2 दिन के अंदर 2-4 महीनों में इसको दौड़ने लग जाएगा आपका बच्चा। उस आशा और उमंग और उत्साह के कारण वहां लगे रहते हैं, और एक के बाद एक न जाने कितने लोगों के पास जाते हैं, क्योंकि हर जना इंडिविजुअलिस्टिक काम कर रहा है, क्रॉस कंसल्ट। यू ऑल नो द स्टोरी। एक घर का लड़का गया और माँ से बोला, माँ इस पेंट को 4 इंच छोटा कर दो। भाभी के पास 4 इंच छोटा कर दो, छोटी भाभी, बड़ी भाभी, बहन, हर एक को बोल के आया, हर एक ने मना कर दिया, और शाम को जब आया तो वो पेंट हाफ पेंट बन गया, हर एक ने काट दिया। When there is no communication amongst each other, even in the families also, we do need it in our professional life. So kindly put your foot in the same shoe and work with these families. They are lovely families. They will give a lot of love and respect to you all. These are this is my first publication before Dr. Mehta gave me a chance to publish in the textbook. After that, we published this on. So these are some of the publications. I will be very happy. There's a lot of motivation. If no hands, the legs. So must make sure that they have a lot of good motivation. You should motivate them. And these are the, she underwent actually this girl, ITB, and she was very much motivated girl. One of our, and he became doctor, and she is a psychiatrist, got married. So this is great pleasure. This is my native place, Udaipur, a good city, and now I'm in Hyderabad. Thank you very much. Namaskar.
Thank you, Dr. Purohit, for nice work and presentation. If there are any question from the audience, he'll be happy to answer.
Thank you very much, sir. Excellent lecture, sir. So how do you decide patients for stereotactic procedures of brain versus peripheral selective motor fasciculotomies for dystonia?
Yeah. He is Dr. Jatin in Jabalpur, and I'm very happy that he is one of the youngster. He's taking up this as his passion, and he has got even the ICMR grants also. So good question. One is that from here, if you want, it is either hemi or a diffuse one. Now you want the lesioning, there are chances of recurrence are a lot. You may go for the non-ablative procedures. Yes, good. But the problem is our families, they refuse for this particular implant on the brain, one thing. And when we have a peripheral solution, then why to touch the brain? And these ablative procedures, you select correctly, then they are permanent. They have not to depend on this thing. So I don't find that the hemi dystonic patients are too many. In my practice, I have not found that one. Mostly they will have some focal or segmental dystonia, which by peripheral solution, we should be able to deal with that. But in some indicated, well, yes, stereotactic lesioning or deep brain stimulation is a choice also in some selected cases, a few only.
Thank you, sir.
Some more question, please. You must be having so many doubts.
No, sir. I mean, the dystonia patients, their dystonia are somewhat variable. Sometimes in this hand, sometimes in elbow, sometimes the arm, and they are themselves difficult to say which is problematic more for them. I mean, I have little experience, so I'm just telling about mine.
Yes, very right. That is
yeah.
why I said that clinical things
Yes,
have
sir.
become much more important in this era of diagnostics, because so many incidental lesions you start treating if you do not have a clinical knowledge. So please remember that in this era too, the clinical is very important, and especially for the dystonias, because you have to see which antagonist is how much working and which agonist. So that requires a lot of experience. And then on the table, how much to ablate? That is
Yes.
another thing. And you must make sure that it is in staging procedures. You might require later on something. So a confidence of them in you is very important. And that is an art how you develop that confidence.
Thank you, sir.
So may I ask you? I wanted to know, you stimulate each of the fascicles to find how much to take out? How do we identify which muscles?
That's right. Now, say for example, pronator, teres, and quadratus. This is one of the common thing in spasticity as well as dystonia. So there will be a proximal branch, another will be running on the main trunk. Now you know clinically that how much dystonia or spasticity is there. So I will stimulate all of them and make sure that what I'm going to cut is roughly producing hyperkinetic movement on the table. Usually we go for 35 to 65%, means 1/3 to 2/3 ablation. Some of them we definitely leave it. In teres, you are very close to the muscle. In pronator teres, you are little away. So the long segment, you can just split into two and then divide.
During the staged procedures, do you find scarring a major problem? Because if you want to go back the whole place.
Excellent question. And that is why we put some tag inside of the silk thread that on the same nerve, if we have to come again, yes, we should be able to do that one. So that's very important thing. Hardly a few times we have to undergo, but those who are initially starting should ablate less. And then if required, you can go after a few weeks on the same place, pull up the thread, and you are on the fascicle. Keep the thread knot or the tail subcutaneously.
Thank you, Dr.
Thank you once again for the opportunity which Dr. Anil gave, and then Dr. Sumit planned all the scientific sessions. Very happy to see that one. Thank you.
I think. Hello. Yeah. I think there is a recorded presentation. I think is this recorded? Next one. Online. Yeah. About a nerve and brachial plexus repair. Should we have a macro or micro view by Professor Mariano Sokolovsky?
Good afternoon. My name is Mariano Sokolovsky, and I will speak today about macro or micro, which is the best vision in peripheral nerve surgery. First of all, I want to say thanks to my dear friend Indira for inviting me to speak in this Congress. I'm sorry that I couldn't be in person, but I have to stay here in Argentina because it's summer vacation here. So I'm with my family planning my trip. Anyway, it's a very big pleasure to be in this Congress. I've been here 3 times before. So I have many friends in India, and I say hello to all of them. Okay. If I say this title, you will think that I will speak about using loops or microscope in a surgery, but no, nothing to see. This is my point. This is a picture of part of my team, Dr. Dimasi, my assistant, and Karina, our nurse, there at the OR. So as surgeons, we always look at the surgical field, which is, of course, normal. But if we take a look to the anesthesiologist, and actually this is my wife, Veronica, who is an anesthesiologist and works with us, the anesthesiologist has a different view of the patient. We just focus ourselves in the surgical scenario. But the anesthesiologist has a whole view of the patient. So they have to take care of the blood pressure, heart rate, and so on. This is the point that I want to focus. Because surgeons, as we take a look at the surgical field, so we have a type of micro view of the patient. By contrast, the anesthesiologists have the whole view of the patient. That's a macro view. So, in my opinion, and again, this is my point, we surgeons should act micro in the surgical field, but think the patient macro, in a macro view, like the anesthesiologist. Let me show this with some examples. For instance, for type of macro thinkings, there are many types of macro thinking. I'm just referring to 4 examples. Brain plasticity is the first one. You might know that we study a lot on brain plasticity, especially in our group as neurosurgeons. So the plasticity is the central nervous system's ability to reorganize and adapt to internal or external changes. It's a normal process in neural development. So when we learn to ride a bike, first we do it under voluntary control, and then we do it automatically. So look at this patient. He had spinal to musculocutaneous nerve traffic. Take out the sound. So anyway, good M4 elbow flexion, normal result. But spinal to musculocutaneous. So take a look of the function when I ask the patient to shrug the shoulder and stimulate the spinal accessory, the elbow flexes. Elbow flexes with the original motor program, the donor motor program, which is the spinal accessory, the 11th nerve. 10 years after the surgery, this other patient had the same surgery. Good result, good M4 result, everything is okay. him to shrug the shoulder, again, he flexes. So bone plasticity is quite important because depending on which was the donor nerve, and I've shown spinal accessory to musculocutaneous and the receptor, the result. So many times we think about brain plasticity as a static thing. It is not at all. The brain changes all the time. So you can see before the surgery, in this picture, a white matter connection, which is there, that connects the motor and the receptor donor motor program, the intercostal in this case, and the musculocutaneous. So this combined program exists. For instance, when we lift something heavy, as in the picture, we have to, of course, flex the elbow, musculocutaneous, but also we have to contract the intercostal muscles to stabilize the thorax. So there is a connection, a existing connection. What we do in surgery is stimulate that connection in order to take control of the lost function. So after the surgery, in an early phase, once the patient already started to recover, there is a strong influence of the donor motor program, in this case, the intercostals. So the intercostals do have the control of that movement. So the patient breathes and the elbow flexes. But after some time, the original receptor or the injured motor cortex regains control. So this is why the changes occur at the brain. And the patient regains control that does not depend entirely on the donor motor program. That's why the patient, as you can see here, with an inspiration or an expiration or whatever, they don't need to move it. They just flex the elbow independently. But if I ask them to inspirate or expirate, then they will move anyway, the elbow. So there are some concepts or some articles where you can see the concepts of brain plasticity. Those are some articles that we published, but there are many others. So this is the phrenic to musculocutaneous nerve transfer, and we analyzed the respiratory effects of elbow control. And we saw, this was published in JNS in 2018, 5 years ago. And you see that the patient gains near 10% of the strength when the patient inspirates, because they inspirate, they discharge the motor cortical program of the phrenic nerve, and then the strength is much better, 10%. So in deep inspiration, 10% more, which is logical. So this is what we call good plasticity, because the patient learns that, okay, they can move without inspiring, they can move and flex, and everything is okay, a good and forth. But if I ask the patient to lift something like one box, okay, she will do it, no problem. But if I ask her to lift 3 boxes, for instance, which is heavier, then she can inspirate, get 10% more, and then get the elbow flexion. So that's the point. The patient can use this type of plasticity. Again, we call that the Popeye effect. It's like the spinach for Popeye. The same happens in contralateral C7, and I assume that my dear friend Anil Bhatia had shown in this congress very nice results on contralateral C7 after a brachial plexus injury. So this is a patient that was not operated by me. It was at this moment training under a Subin, a physiotherapist from India. And then you see that when he contracts C7 in the left upper limb, which is the normal, the healthy side, there is a contraction. So this is the way we train contralateral C7 in order to regain more control. But you see, there is a connection. So plasticity, again, is always involved. So no matter which kind of nerve transfer, you have to have the macro view. I'm not saying brain plasticity is bad or is good. I'm saying brain plasticity should be used if we think the patient in a macro way. So depending on which are we transfer to which nerve, to which lost function, neuroplasticity can be involved. So we measure the plasticity, and we saw that always in more than 80% of our cases, brain plasticity is limited in adults. So they always keep some part of the original movement in order to get the regained movement. That's a track of our nerve reconstruction. And this is another article where we analyze babies, and we realize also, using a good scale to measure clinically the plasticity of the brain, that the babies do regain much better plasticity, which is, of course, logical. So my conclusion is brain plasticity is limited in adults, but wonderfully good in babies. So again, speaking about this macro view, brain plasticity is something you have to care about. So again, we surgeons should act micro, but think the patient macro. Geography is another topic which I like to refer to, because it is also important, because in BPI surgery, there are lots of interesting papers, but where do they come from? This is important. For instance, this is a paper we published some years ago where we compare two populations of patients, one European from Germany and one from Latin America, Argentina. So we saw many differences in the population. This is the number of cases, and we saw that the Germans were older, were taller, and were heavier than their Argentinian counterparts. This means that the patients, the population of patients, were completely different from Argentina and Germany. In fact, we have a lot of much more complete flowing arms, complete lateral plexus injury, than when we compare with the European counterparts, which has more frequently upper trunk injury. That's why I was wondering, why do Europeans say that the upper type brachial plexus injury is much more common than the flail arm? In our cases, no. I assume that in India, neither. So this is important. And again, geography is involved. For instance, obese patients have a heavier limb. So the results are good or are bad. Is it the same to operate on a heavy patient than on a very slim patient? So we analyzed intercostal to musculocutaneous, and we saw PubMed. And look at this. We saw that in the Eastern countries, like Japan, China, Taiwan, and of course India, the results were quite good. And at the same time, the BMI was always below 25, which is a skinny population, thinner population with not so heavy limbs in order to move. So when we compare these populations with the results of the series of intercostal to musculocutaneous in the Western countries, namely Europe, North America, and so on, we saw that the BMI was always above 25. So we analyzed this, and we realized that the results were completely different. So we analyzed also the spinal to accessory nerve transfer, and we saw a significant and moderated negative relation. And for elbow flexion, we didn't see any relation, which is logical because it is not the same to flex the elbow than to lift the whole upper limb. So that's why BMI is involved, but it's not completely involved. Anyway, when we see a patient, this macro thinking I was speaking about, we might be comparing apples and pears. If we see a very thin patient, and at the other time we are treating a very obese, let's say, patient, and we apply the same technique, the same surgical technique, we might fail. And that's my point. Again, surgeons, okay, we should add micro, but we should planify the surgery in macro way. And to finish, some things that can be changed by patients, for instance, that cannot be changed. For instance, the age, of course, cannot be changed. So we separate our patients in 3 groups, one younger, second middle, and third, the older patients. And we saw that as age increases, the results in terms of the strength that we obtained were worst. Older patients were result in terms of strength. But again, this is logical because as we improve our age, the muscle tends to start to atrophy and diminish its weight. So that's why the results are not so good. Again, we publish this in operative neurosurgery, as you can see if you want to look for it. Again, the same concept. Act micro, think macro. And finally, changeable factors of the patient, something that can be changed. For instance, rehabilitation. We are completely sure that those patients that do rehabilitate better, they get a better result. And we publish a lot on that. This article was published, I think, in 2011. Look at this, 13 years ago, using long graft. Anyway, but we saw that the more compliance the patient had with the rehabilitation, the better result they had. And this was statistically significant. And we developed this rehabilitation quality scale, and we saw that those patients that do rehabilitate better, they obtain much more frequently a grade 4, not to mention brain plasticity again. So, and this other article using phrenic nerve as donor, again, same statistically significant result. So again, what do I mean with this macro thinking? For instance, if we are speaking about rehabilitation, the first time you see the patient with a brachial plexus injury and you are planifying the surgery, what we do is to speak with the patient and tell them the importance of the rehabilitation. We say to them, okay, when I operate you, everything's going to be okay, hopefully, and you will get healed after some time, and then you have to start the rehabilitation, and then the responsibility is transferred from me, the surgeon, to you, the patient. So you have the responsibility to rehabilitate properly. So again, in a macro thinking, taking care of the whole patient, we might adapt our treatment, but we have to think it. So again, this is for finishing. You see our micro thinking during the surgery, but our macro thinking before and after, like our colleagues, the anesthesiologists. Thank you a lot for your attention. Bye-bye.
Obviously, we cannot ask him questions because he's vacationing. Where is he? Oh, he's there. Oh, yeah.
Hello, can you hear me? You are on mute, I think.
I'm sorry. Yes, can you hear me?
Yes, now we can hear you.
Yeah,
So that was an excellent presentation. And what I wanted to know was that in your macro vision, how is it that you're implementing it in patients with brachial plexus injury? Or you do more rehab or neuro rehab for these patients, or some kind of biofeedback to encompass the macro view? Or is it the operatively only you introduce some other facets to it?
No, the hybridization process is quite important. So it's a stage procedures. For instance, at the very beginning, the muscle is silent, there is still no response to our surgery. Then the strength starts to recover. So at that stage, you have to recover mostly the primary motor cortex in order to ensure an M4. Then after getting the M4, you have to start to work on brain plasticity. What does this mean? That you have to train premotor cortex in order to reorganize the white matter to get independent movement. So it's a stage rehabilitation. It changes over the time till you get your maximal result. That's an example, humble example, of course, of the macro view.
Okay, thank you.
Excellent presentation. And I'm Dr. Purohit, neurosurgeon from Hyderabad. I appreciate these two words, micro and macro. And in our culture here, we use the two words, concentration and mindfulness. So what you said, micro is a concentration and macro is the mindfulness. So the combination of the two goes in a story of Arjun hitting the eye of a bird. At that time, what he was asked, he says that I can see only the eye. Is the concentration is a micro. But at that time, he should have the whole view of the tree and of the forest, and that is called as the mindfulness, Dhyan Magnata. Congratulate you on micro and macro. Thank you.
Thank you very much for your kind comments. I I do meditation every day, and I learned that from your wonderful country. So once again, I learned something else from you.
Other than rehabilitation, is there any way to improve the timeline of the neuronal plasticity? Is it possible to stimulate those areas to improve this plasticity, or is it just a time-dependent function?
Yeah, probably there will be more developings on this field in the next future. At this moment, which is on our possibility, the rehabilitation is the most important action we can take. But probably different types of rehabilitation focusing on brain plasticity will develop after this starting knowledge on brain plasticity after nerve transfer. So I'm sorry, I cannot give you right now an answer. Probably in the next future, yes.
Are there any more questions? Okay, thank you. Thank you so much for coming online.
Thanks to you. Thanks to you. Bye-bye.
Bye-bye. May I invite Rajiv Sharma? I think he's online on Zoom. He will talk about the surgical aspects of the carpal tunnel syndrome. Hi,
good morning, everyone. First of all, I am thankful to the organizers, especially my friend Anil, for organizing this excellent conference. I'm sorry for not being there present because of some personal reasons. Coming to my presentation. Is my presentation visible to all?
Yes, it's visible.
Can I proceed?
Yeah, please proceed.
You can carpal tunnel, as we all know, is the focal entrapment mononeuropathy of the median nerve, and it's seen in around 1 to 5% of population, more commonly in females than in males, and especially in adults around 40 to 50 years of age. If it's it's a bilateral disease, but usually seen early or initially in the dominant hand. Anatomy of the carpal tunnel is the reason behind all this, as we can see in this cross section of wrist that carpal tunnel is surrounded on three sides from the bone and on the upper side, on the palmar side by the flexor retinaculum. And this is a closed cavity where and containing the tendons and nerves. And whenever because of any reason this space is confined, this confined space pressure increases, this leads to compression of this median nerve. And this is the branches of this median nerve, and we can see the important palmar cutaneous branch which is proximal to the flexor retinaculum, and then hence this is never affected. And this is another branch, recurrent branch, and this needs to be protected during the surgery. I'll go into these details later. We should always be aware of the various anatomical variations in the branching of this median nerve or in the or in the palmar arterial arches, so that during surgery we don't injure any of them. This is another image of recurrent motor branch which needs to be preserved. We should know which part of the hand is innervated by median nerve, so that we are aware about its functions and we are able to check them pre-op and post-op. In the carpal tunnel, median nerve doesn't give any branch, but after leaving the after leaving the carpal tunnel, that means after at the distal edge of flexor retinaculum, it branches many times. This branching carries a lot of variations, and but the innervation is usually constant. It innervates the first and second lumbaricals, opponens pollicis, abductor pollicis brevis, and flexor pollicis brevis. High pressure within the carpal tunnel is the reason of this compression, and this can be because of combined pressure or traction forces. And these combined traction or compression forces increase pressure within the carpal tunnel, leading to obstructed outflow, leading to impairment of microneural circulation within the nerve, and thus nerve dysfunction. Various risk factors are there, especially the commonly seen are the metabolic factors like acromegaly, hypothyroidism, or diabetes. Occupation, it's often occupation related, and sometimes it's seen in youngsters with improperly healed Colles fracture. Symptoms, as we all know, sensory fibers are more sensitive than motor fiber. That's why this neuropathy presents with sensory symptoms initially in the form of pain, numbness, and paresthesias. But as the disease advances, it can lead to weakness of the thenar muscles. Most of the symptoms, sensory symptoms, are seen at night, and or in the if it is seen in the daytime, this because of repeated activities. We can see this diagram showing the various patterns of presentation of sensory symptoms: numbness, pain, tingling, or decreased sensations. And we can see it's seen only in the territory of median nerve. How we can rule out carpal tunnel syndrome? There are there are some classical cases where we can just by clinical diagnosis we can confirm the diagnosis of carpal tunnel. There are some features in that we can on clinical grounds we can rule out this is not carpal tunnel syndrome, like involvement of the fifth digit, or sensory loss of the thenar eminence. This is all related because this median nerve innervation is in the 3.5 digits on the radial side, and on the ulnar side 1.5 digits. This is innervated by ulnar nerve. As I discussed already, various sensory symptoms. This is the sensory findings typically spare the thenar eminence because the palmar cutaneous branch leaves it before entering into the carpal tunnel. And various tests are described. And this is the chart which is showing the sensitivity and specificity of various symptoms and signs. And we can see that Phelan's maneuver or median nerve compression test. These are some of the tests which carry very high and flick sign. These carry very high sensitivity and specificity for diagnosis of this carpal tunnel syndrome. Before confirming the diagnosis, we should always rule out all the possible differential diagnosis so that we are correct. As I told you, in typical presentations, clinical diagnosis is sufficient to make the diagnosis. But in atypical cases, testing is required. All the cases should undergo metabolic workup to identify the metabolic cause and needs to be treated. Imaging is required only in cases of structural abnormalities. This is the Bland's classification in which neurophysiological grading can be done, and we can see mild, moderate, and severe. Mild and moderate usually can be managed medically, whereas severe compression required surgery. Medical management or conservative management requires nighttime splinting, modification of activities, steroid injections, and ultrasound. This is the technique of giving the intracarpal steroid injections. But we should be careful about injection pulses by this technique. Surgical indications is severe carpal tunnel syndrome or patients who are not responding to 4 to 6 months of conservative therapy. And before doing surgery, all the patients should undergo testing of electrophysical testing, nerve conduction studies, and electromyography. And these are the current recommendations of practice, and we can see that short-term treatment by conservative treatment is quite effective, and surgical modalities, endoscopy and open, are equally effective. Goal of surgery is to relieve the median nerve compression by dividing the transverse carpal ligament. Usually, it is done under anesthesia, local anesthesia, and there should not be any adrenaline mixed in it. It should always be done under magnification. Let it be loop or microscope or endoscope, whatever is available with the surgeon. No tourniquet is used. Incision for the beginner, it usually starts at the distal wrist crease and ends till the Kaplan line. But as the surgeon gains the experience, they can shorten it as per their expertise in the current minimally invasive era. Usually, the structures cut are skin, subcutaneous nerve, subcutaneous fat, palmar, aponeurosis, and transverse carpal ligament. Number 15 blade is usually sufficient for open cases. This is the one image where we can see the incision starting from distal wrist crease to the Kaplan's line. And in cases where there is a intra, when we see that there is more proximal compression, we can extend the incision in slightly curvilinear manner to avoid contractures. This is a diagram showing the various different incisions for the different types of procedures available. This is one case I had done in which I have decompressed the whole nerve completely, and we can see that there is a small muscle, but that muscle was not cut as there was no compression because of it. Meticulous hemostasis is very important at the time of closure, and suture removal is done on the day around day 10 to 14. Post-op advice is very, very important. Patients should keep on doing all activities gently, and hand activity should be reduced for 2 to 3 months till the scar matures. There is no proven benefit of doing internal neurolysis in every case, but in cases of recurrent disease, internal neurolysis of median nerve may be done. This is another case. Meticulous closure is very, very important. Another technique is endoscopically, and this endoscopically there are two techniques: dilator assisted or retractor assisted. And I feel retractor assisted is more safe, as it improves vision and doesn't introduce any instrument in the carpal tunnel. Various complications. Every surgery carries a risk of complications, especially the important one are recurrent motor branch of median nerve injury and distal ulnar nerve injury. Distal ulnar nerve injury, it can happen because of the retractor we apply for exposing the median nerve. I have my own set of complications. This was one case I had operated. Patient suture removal was done on day 10, and after that, this lady was started doing all household work, and within a week she came with a slight wound gap. And the mistake we did was we didn't reinforce that she should not use this hand routinely for all household work. And within a week, the wound settled down. Outcome, as it's a progressive disease, it should be it requires treatment, and patients who underwent surgery within the 3 years of initial manifestation, they really respond very well. And the presence of axonal loss in electrophysical testing indicates poor prognosis. All cases carry some risk of recurrence, especially after 5 years of disease. Coming to recent advances in MR neurography has been used and some atypical cases to identify the nerve compression directly. Another recent advance, this is a minimally invasive era, we all want to give a smaller incision as per the expectation of the patient, and thus a minimal invasive open carpal tunnel release technique has also been described. In this, we can see there's a separate set of instrument is required for this, and in this, incision is given at this at a line at the intersection of the line joining the Kaplan's line and the longitudinal line passing on the radial side of the ring ligament. And this incision can be this incision is usually around 1 to 1.5 centimeters compared to the conventional one, which is around 3 to 3.5 centimeters. Coming to a video. This is a video of a conventional open carpal tunnel release. We can see we have to first see the markings. What marking? This is a distal wrist crease, and incision starts from there till the Kaplan's line. And this is the this incision should be slightly on the ulnar side. This is the side where we expect our median nerve to be there, and incision should be slightly on the ulnar side so that
Rajiv, the video is not playing.
incision should not fall directly on the median nerve. We are doing a local anesthesia, and
Rajiv,
after that, hello.
The video is not playing.
Are you not able to see the video?
No, we are not seeing the video.
Just a minute. Is it visible now?
Yes, it is visible.
Yeah, incision has to be slightly on the ulnar side so that it should not fall directly on the median nerve. This reduces the incidence of delayed failures. And we have to cut layer by layer, skin, subcutaneous tissue, pulmonary fibrosis, and then we will see the median nerve synovium. This is we have reached the flexor retinoculum. We have to start in midline and then we have to go proximally and distally. We have to start somewhere in the middle. Flexor retinoculum release has to be started somewhere in the middle, not at the either of the ends, because at the ends there are important structures which needs to be safeguarded. And from midline we have to go both proximally and distally. Now you can see this is the nerve. You can see the synovium bulge. This is flexor retinoculum is being cut. Yeah, we can see the whole of the we are seeing proximally if there is anything left, and we are trying to cut if any other band we are able to see or we are able to feel with the instruments or with fingers. Passing a small number 4 penfield dissector, we are trying to feel any contracture or any tight band with the finger, and if it's felt, it can be cut to complete the release proximally. Similarly, it can be done distally, and we are detecting the flexor retinoculum. We can see, and this is the hole is the exposed nerve. Once we are sure that we have done the complete flexor retinoculum release, then we can close subcutaneous tissue and skin in 2 separate layers, or single layer closure also has been documented. Coming back to my presentation. Thank you so much.
Do we have any? Yeah, Rajiv, are you going back into the PowerPoint or have you finished the presentation?
Yeah, I have completed my presentation.
Oh, okay. Do we have any questions for Rajiv? Rajiv, if I may ask you a question.
Yeah.
If the you have diagnosed a carpal, once we have diagnosed carpal tunnel syndrome, if the electrophysiology is completely normal, do you hesitate or do you still operate?
Usually, electrophysiology physiological demonstration of compression is a must. Usually, we get delayed latencies. That is a must to operate, a must criteria to operate any patient. If that is not seen, either we should repeat electrophysiology from another place, or we should review our diagnosis. Our diagnosis might not be correct if electrophysiology is not showing delayed latency.
Okay. Can I ask you one question? I am Dr. Purohit from Hyderabad.
Yes, sir. Good morning, sir. I can
Yes,
recognize your voice, sir.
Okay. Rajiv, nowadays in our practice, we are finding, and especially I'm finding that the gabapentin and some other conservative measures are giving very good results. Many cases, we are avoiding the surgery. So what is your experience of this particular medication?
Sir, in my presentation, I showed this mild to moderate cases we can very well manage conservatively, and even for those cases, guidelines says we should manage medically for initial 3 to around 6 months, and if medical management fails, only in those failure cases we should go for surgery in mild or moderate cases.
Right. Thank you.
Thank you, sir. Thank you, sir.
Hi. So I just have a question. For example, when you are
taking a patient of carpal tunnel syndrome for the surgery or something like that, how often you evaluate the local factor which is causing the carpal tunnel syndrome and taking care of that during the surgery so that the recurrence will not be there? For example, the friction injuries, because once you release the carpal tunnel, if there is a friction injuries, there will be definitely the recurrence. So how often do that? And second, how commonly you find tenosynovitis mimicking with the carpal tunnel syndrome and leading to the surgery unnecessarily?
Uh, very good question of yours. First of all, coming to whether our diagnosis of carpal tunnel syndrome is correct or not. Usually when we, as I told, this carpal tunnel is a closed cavity. Once you release the flexor retinoculum, the pressure is gone over the nerve. So usually, if like if there is any hypertrophy or if any soft tissue in fractures of old Colles fracture, you cannot do any surgery in those cases. So the only easiest way to relieve the symptoms in that improperly healed Colles fracture is release the flexor retinoculum. If you try to manipulate the bone by doing any osteotomy, that will be more extensive surgery with the questionable benefit. Flexor retinoculum release surgery is easier than doing any Colles correction surgery for relief of pain in such case. So that's why I feel flexor retinoculum release surgery is better than regarding need to do any anatomical study. Frankly, I have experience around operating around 15 to 17 cases. I have not done any anatomical study of like MRI or any CT to see the bony anatomy. Just gross clinical examination. If it is normal, I think it's not required. Any bony bony or soft tissue anatomy demonstration by CT or MRI, I think it's not required. But yes, if you suspect ganglion or if there is a localized swelling and you feel there is a ganglion cyst, in those cases, because treatment will be different. If you suspect there is a ganglion, it will require ganglion surgery rather than flexion retinoculum release surgery.
If there is no question, now we conclude the session. Thank you.
Thank you so much. Thank you, organizers. Thank you, chairperson. Thank you, everyone.
Thank you very much, sir. I would like to thank our chairpersons for this session. Thank you, sir. Our next session will be peripheral nerve tumors, peripheral nerve surgeries, challenging cases, and outcome lessons. I would like to call upon our chairpersons for this, Dr. K.K. Boy, Dr. Sunil Kalda, Dr. Abhijit Koat, and Dr. Krishnanand Duru.
So I would like to invite Dr. Aparajita Saha for her presentation.
Good morning, everyone. My topic is adult traumatic brachial plexus injury, our institutional experience. Brachial plexus injuries are devastating, life-altering injuries and they result in notable physical disability, psychological distress, and socioeconomic hardship. Variety of etiologies are responsible for this, like penetrating injuries, falls, motor vehicle trauma. Most are closed injuries involving the supraclavicular region, and torque of the head violently away from the shoulder leads to upper plexus injuries, while violent overhead abduction leads to lower plexus injuries. Our aim was to assess the number of patients coming to our OPD, how many were lost to follow-up, number of patients we have operated, and number of patients with spontaneous recovery. Also to assess the outcome and functional gain in operated patients. It was a retrospective analysis in the last 5 years, and most of the patients were aged between 16 to 60 years. Among 250 patients who presented to us in OPD, 100 patients were lost to follow-up, and among 150 patients, 100 patients we have operated, and 50 patients had spontaneous recovery. And most of the patients were males, that is 97%. And 98% had motor vehicle accident high velocity as the cause of injury. 77% of them had pan VPI, 17% as upper, and 5% as lower VPI. In all patients, we have done a preoperative MRI of the brachial plexus of the involved extremity and electrodiagnostic studies. All the patients were followed up for 2 years, and patients were advised for physiotherapy to keep the joints supple. These were the surgeries which we have done. 45 patients we have done SN to SSN transfer, ISN to MCN in 30 patients, Oberlin 15 patients, and Somsax procedure 6 patients. We have done combined approach, that is 4 patients. In 4 patients we have done SN to SSN with Oberlin and SN to SSN with Somsax transfer. And exploration with nerve grafting was done in 4 patients. This is a picture of a patient in which we have done SN to SSN transfer after dissection and skeletonization of both the donor and recipient nerves. We have done under microscope guidance, we have done an epidural repair with 10-0 nylon sutures. In this patient, we had done anterior approach, and we have done exploration of the upper plexus, and C5, C6 upper plexus were injured with a gap of more than 6 centimeters, for which we have taken a sural nerve, and the sural nerve reverse graft was done for the ends. Under microscope guidance, we have done epidural suturing with 10-0 nylon sutures. Intercostal to musculocutaneous nerve transfer. We have taken the 4th and 5th intercostal nerve, and we have tunneled it in the subcutaneous plane in the axilla, and transferred it to the branch to the musculocutaneous branch to biceps, and we have done anastomosis under the microscope using 10-0 nylon. This is Oberlin transfer. FCU fascicle we have taken, and branch to biceps we have taken. And similarly, last picture shows a coaptation using microscope and 10-0 nylon. And this is FCR fascicle of median nerve we have taken for this patient. This is Somsax transfer, in which we have first we have identified all the branches of axillary nerve, and the anterior branch we have anterior branch of axillary nerve we have coapted to the radial nerve branch to the long head for shoulder abduction. Coming to results, 50 patients had neuropraxic injury, and they recovered at the end of 6 months. Most of the patients were having poor compliance, and hence 100 patients were lost to follow-up. 58 patients had post-ganglionic, and 92 patients had pre-ganglionic injury, and all the patients were operated between 5 to 8 months of injury. Anterior approach we have done in 4 patients where sural nerve is used as the graft. For shoulder abduction, we have done spinal axillary to suprascapular nerve transfer via posterior or anterior approach, and Somsax transfer where I have already explained, branch to radial nerve, branch of radial nerve to axillary nerve we have done. For elbow function, intercostal to musculocutaneous oberlin transfer is done. And preoperatively, we have checked the median and ulnar nerve function of the hand, and it was in all patients it was above MRC grade 4. Staged approach for pan plexus injuries were done for shoulder abduction and elbow flexion with a gap of 4 to 5 weeks in between. And all the patients were assessed for motor function every monthly for the first 3 months, then every 3 monthly for the next 2 years. Immobilization was given for 3 weeks, and following which physiotherapy was started. Shoulder function improvement up to abduction improvement was seen in 6 patients for 30 to 40 degrees, and elbow flexion was seen in 3 patients about 50 to 60 degrees, and in 4 patients we have done combined procedure as they had presented more than 7 months from the date of injury. This is a table showing my final results. Coming to discussion, these are devastating life-altering injuries, and most common cause in our series was found to be road traffic accident, that is high velocity, and most of the patients were males, and right-sided involvement was seen in most of the cases. As most of the patients were from a low, poor socioeconomic status, so follow-up was difficult, and also due to late presentation and functional outcome was not satisfactory. Outcome was found to be better with upper plexus injuries, and pre-ganglionic injury was found to have a poorer outcome than post-ganglionic. In conclusion, I would like to say brachial plexus injuries are complex which need timely intervention. Hence, awareness is important so as to refer the patient to specialized centers so that management can be done at an early date. Thank you.
So the questions are welcome. If there are. Please. Yeah, what was the protocol for the pan brachial plexus in early and late cases?
Sir, pan brachial plexus, we have done stage procedure, sir, shoulder abduction and elbow flexion ke liye. So we have given a gap of 4 to 5 weeks, and all the patients who had presented to us early, we have operated at 3 months, within 3 to 4 months. And whenever the patient approached to us late, sir, more than 7-8 months, we have tried to do a combined approach. I have already told, sir, 4 patients had presented late. So shoulder abduction and elbow flexion ke liye, we had operated both SA into SSN and IC into MCN in 2 patients, and SA into SSN. That's pan brachial plexus only, sir. Upper ke liye also we have done combined approach in 1 patient. 2 patients.
Anything planned for the hand function?
So no, sir, not yet.
Pre-ganglionic cases have poor outcome in overall.
Yes,
but
sir.
in early cases, in comparison, in pre-ganglionic cases.
Sir, yes, sir. In the 6 cases where shoulder function has improved, sir, 6 cases, shoulder function we have achieved for 30 to 40 degrees, sir. In that, there were 3 patients of pre-ganglionic injury only, sir. Pre-ganglionic pan brachial plexus injury only, sir.
So I would like to ask you once, how commonly use MRI of the plexus for in your cases, your 50 cases? So how many patients you did the MRI and how it was helpful?
Sir, we did MRI for all cases, sir. And it was helpful in diagnosis of pre-ganglionic injury, sir. And also to for correctly telling us which roots have been avulsed, or if there's a clear-cut avulsion or a neuropraxic injury is there, that it has helped us, sir. Pseudomeningeal seal or formation, all that.
So no more questions. Thank you, Dr. Aparajita. So now we are moving to the next talk by Dr. Sumit Bansal. He is going to speak on the unusual peripheral nerve tumors, the Bhubaneswar AIMS experience.
Good morning, everyone. Respected chairpersons, faculty, and delegates.
First of all, I would like to thank the organizing committee of Ispnscon 2024, especially Dr. Anil and Dr. Shamendra for inviting me, and also to the Indian Society of Peripheral Nerve Surgery for giving me the opportunity to present this paper. I am presenting unusual peripheral nerve tumors at our center at AIIMS Bhubaneswar. Greeting from the our Department of Neurosurgery. Peripheral nerves are relatively unexplored in comparison of other areas like cranial and spinal surgery, especially for neurosurgeons. And major neurosurgical problem of peripheral nerves are injuries, entrapment neuropathies, and tumors. Peripheral nerve tumors can be benign or malignant. Benign may be schwannoma or neurofibroma. They are identified as slow-growing, painless, smooth surface with encapsulated area, and enucleation is possible in these benign tumors. Other tumors are malignant, like malignant peripheral nerve sheath tumors, parachordoma. They are identified as for rapid growth, having pain, lobulations, and infiltration outside the capsule. And excision is the treatment. First case is swelling in the forearm, in the arm, a diffuse swelling. On exploration, there was a tumor in the median nerve in the arm. After consent, this was explored, and enucleation was not possible because it was involving whole of the nerve. So a sural nerve graft was done, and biopsy came out to be schwannoma. Another case is a tumor involving posterior cord of the brachial plexus. This was attaching to the axillary artery. So with the help of cardiothoracic team, we detached this from the axillary artery and removed this, and biopsy came out to be malignant peripheral nerve sheath tumor. Another case is tumor in the axilla. On MRI, there was a contrast enhancement along the nerve, and it was enucleated, and function was preserved. Another case is unusual tumor, initially thought to be schwannoma along the median nerve on the forearm in a middle-aged female. Enucleated, patient remained preserved postoperatively, and biopsy came out to be surprisingly parachordoma. It is a soft tissue tumor, and only 19 cases are reported till date in the upper limb. These are locally malignant tumors from the soft tissue, and annual follow-up with or without radiotherapy is directed in this type of tumors. We have reported this case, but after annual follow-up and after 6 years of follow-up, this patient came in 2023 with recurrence at the same location in the forearm along the median nerve. And after consent, this was re-explored and tumor was sent, but biopsy came out to be parachordoma again. Patient remained preserved even after the surgery, and patient is under follow-up right now. Another case is tumor along the ulnar nerve. That was schwannoma. Enucleation was done and preservation of function was there. Another is a tumor along the lateral side of forearm. Initially, it was diffuse swelling on the clinical examination. There was no movement along the nerve, but on MRI, there was suspicion of nerve tumor. So we explored this tumor and found a tumor arising from nerve, maybe sensory nerve. So we enucleated this, and this came out to be schwannoma. Another tumor is a patient with 45-year-old female with left leg swelling on the medial side. And on doing MRI, there was a diffuse swelling along the tibial nerve with infiltration into the surrounding areas. muscles. So we explored this area, and there was a diffuse tumor involving the tibial nerve with the involvement of surrounding muscles. Debulking was done. Primary reconstruction was not possible because of this involvement of surrounding tissue. And biopsy came out to be malignant peripheral nerve sheath tumor. And patient is under follow-up of radiotherapy. Another case is swelling over the peroneal compartment, lateral compartment of right leg. On doing MRI, there was a tumor along the superficial peroneal nerve. On exploration, tumor was enucleated and biopsy came out to be schwannoma. So take-home message is clinical and radiological diagnosis is helpful in preoperative diagnosis of tumors of peripheral nerves, and good outcome is expected in benign tumors like schwannoma. Malignant tumors like MPNST and parachordoma require radiation oncology follow-up. And nerve grafting is avoided in malignant tumors, especially involving the surrounding tissues like muscles. Thank you.
That case, the parakodoma recurrence, radiotherapy was not given.
Not given.
In the first.
Yes.
First time.
She was under follow-up, but after 6 years, she came with same tumor in the same site.
Now radiotherapy is not given. Second
Just
time.
now, 1 month back, she was reoperated.
In chordoma, the proton beam therapy is being indicated. Am I right for this case? Also, I'm not very sure. What about chondromas and proton beam therapy?
Sir, in chordoma, like in clival chordoma or sacral chordoma, we give proton beam therapy. But this is parachordoma. This is not different from chordoma. For this, if recurrence or there is a local infiltration, radiotherapy is recommended. Thank you.
Next case by Dr. Ajay Khandar, lumbosacral plexus, neurogenic tumors, tips in management and our experience. Please.
Good afternoon, everyone. My name is Dr. Alay Khandar. I'm the final year resident from Hinduja Hospital, Mumbai. So today my topic of presentation is lumbosacral plexus neurogenic tumor, our experience. Yeah, so the lumbosacral plexus neurogenic tumor are rare tumors, and very few large series are reported in world literature. The histopathological nature is also unpredictable. However, the benign tumors are more common than malignant peripheral nerve sheath tumors, except in one of the literature where out of 85 patients, 43 were malignant peripheral nerve sheath tumors. And in our case, in our series, out of 42 patients, only 2 patients were MPNST, and out of 40 patients, 32 patients were schwannoma, and the rest were neurofibromas. Also MPNST are often secondarily involved by the lumbosacral plexus tumor with metastasis from the rectum, urinary bladder, or prostate. And they are also sometimes they are infiltrate from the sacral plexus from the retroperitoneal sarcomas. So this is the comparison of our series with the world literature. So the most common presentation is neurogenic pain. In our case, all 42 patients presented with neurogenic pain. And other than this, motor weakness and sensory deficits are also common, followed by bowel and bladder involvement and sexual problems. The pain which is there is presented as low back pain or pelvic region pain, followed by sciatica. In the majority of series, and MPNST are typically present with severe pain, which is of rapid onset, rapid progression. So lumbosacral plexus can be divided into two: lumbar plexus and sacral plexus. Lumbar plexus from L1 to L4, and sacral plexus from L5 to S3. So this is about lumbar plexus. Lumbar plexus are formed from the ventral rami of L1 and L1 to L4, and also has the supply from the T12 ventral rami. The laterally we have iliohypogastric and ilioinguinal nerve, which are sensory nerves, and the major nerves. The major nerve is formed is the femoral nerve. So femoral nerve, genitofemoral nerve, and lateral femoral cutaneous nerve, they pass beneath the inguinal ligament, and they supply the anterior and the lateral aspect of the thigh and the muscles of the anterior and the medial compartment of the thigh. Except the obturator nerve, which goes from the obturator foramen, and it supplies the medial part of the thigh and also the muscles of the medial compartment of the thigh. Then the sacral plexus, they are formed from the ventral rami of L5 to S3 roots, and they leave the pelvis through the greater sciatic foramen, and that continues inferiorly and supply the motor and sensory branches to the gluteal region, posterior thigh and leg, and the foot. And the major nerve is the, as we know, it's a sciatic nerve, anteriorly tibial, and posteriorly and laterally peroneal compartment of the sciatic nerve. So in our experience from 2000 to 2023, only 42 patients were in the series. So it shows that it's a very rare tumor. The lower lumbar plexus neurogenic tumor of 19 patients. The most common was L4 root involvement, which was 9 patients, and 23 patients were sacral plexus neurogenic tumor. And in that, 2 patients had malignant peripheral nerve sheath tumors. So this is our institutional review of the all 42 patients from 2000 to 2023. So the age of presentation was between 18 to 55 years with mean age of 32.4 years, male to female ratio of 3:1, and duration of symptoms were 13 months, with malignant peripheral nerve sheath tumors presenting quite early in the presentation. The most common presentation was neurogenic pain in the lower limb. Out of all the 42 patients had neurogenic pain. Paresthesia in 20 patients, pain in the abdomen and pelvis in 17 patients, palpable mass in 4 patients, and wasting of muscles in 7 patients. The motor and sensory compartment involvement also there in about 25%, 10 patients having motor weakness and 11 having sensory impairment. urinary complaints and constipation in 6, and sexual complaints in 3 patients. But important to note is all the patients were symptomatic with progressive worsening of symptoms, so that they were offered the surgery. And NF1 was seen in 4 patients. Coming to the investigations, often the investigation is delayed as the clinical features are confused with lumbar radiculopathy. So these tumor are to be kept in mind when we are assessing the patients. Sonography of abdomen and pelvis can be done. MRI is very much useful. MRI of abdomen and pelvis with plain and contrast imaging are done. This helps to differentiate the benign peripheral nerve sheath tumor from the malignant peripheral nerve sheath tumors. Also important to note in MRI is the relationship of the tumor with the ribs, lumbar vertebra, psoas major muscles for upper lumbar plexus tumors, and for the lower lumbar plexus tumor and the sacral plexus tumors, relationship of the tumor with the pelvic viscera, iliac vessels, and the urinary bladder are to be noted in MRI. Also, for all the patients who had come with neurological deficits, we had also gone for EMG NCV test, physiological monitoring test before the surgery. And in 16 patients, we also did angiography and to see the relationship of the tumor with the aorta, inferior vena cava, and the iliac vessels. So this is one of the example of such 3D reconstructed CT of the abdomen and pelvis for to see the relationship of the tumor with the major vessels in the abdomen and pelvis region. So preoperative biopsy was performed in 17 patients. In all the cases, the help of general surgeon or urologist was taken for the exposure. Trans abdominal approach were done in for all 42 patients. Out of 42 patients, 20 patients underwent retroperitoneal approach, 21 via the transperitoneal approach, and 1 patient underwent posterior sacral approach. So this is one of the study which divides the lumbar abdominal pelvis region into 3. Region 1 is upper lumbar plexus tumor involving the tumors involving T12 and L2, for which he proposed the dorsal or the posterior paravertebral approach. Region 2, which includes L2 to L4 roots, and for that he proposed lateral retroperitoneal approach. And for region 3, lumbar sacral plexus tumors like from L5 to S3, he proposed anterior transabdominal approach. For this lateral retroperitoneal approach, we need to keep in mind about the psoas major muscle, because the lesions are generally embedded within the psoas major muscles, and the chances of ureteric injury and genitofemoral nerve injury is very common, because so it should be safeguarded. Also, for the anterior transabdominal approach, bowel loops, ureter, and internal iliac vessels should be safeguarded. This is one of the literature who stresses upon the need for planning of the surgical approach and the need for multimodal approach in excising the lesion and preservation of nerve function. So, for planning of surgical approach, location and extent of the tumor, which are to be assessed preoperatively via MRI. Type of the tumor, suspected histopathology should be kept in mind, and also intraoperative frozen also helps in such cases. Clinical manifestations and their severity helps us to know about the variety of the tumor, whether it is a benign or a malignant peripheral nerve sheath tumor, and prognosis of such lesions. So in our cases, 42 patients, total excision were performed in 29 patients, which includes 2 patients of malignant peripheral nerve sheath tumors, radical excision in 12 patients, and subtotal excision in 1 patient which presented with recurrent lumbosacral schwannoma. And out of 42 patients, 32 patients were schwannoma, 8 had neurofibroma, and 2 were MPNST. So complications, intraoperatively 7 patients had severe intraoperative bleeding. In 2 patients, bleeding were from the internal iliac, and the repair and ligation was needed. Also, in literature, the importance of preoperative embolization or intraoperative ligation of internal iliac artery has been written in the literature. And 1 patient had ureteric injury which needed repair with stenting. And in our case, no intestinal injury were noted. Post-operatively, one patient had DIC, for which in case of large lumbosacral recurrent schwannoma, and subtotal excision was performed in that patient. Post-operatively, out of 42 patients, 38 patients had improvement, significant improvement in the neurological pain with a VAS score of less than 4. But in 4 patients, the pain worsened for a few months and then eventually improved. And this includes 2 patients of MPNST. The motor weakness in 10 out of 10 patients, 8 had motor improvement of about, so the improvement rate was about 80%. But in 2 patients, new motor weakness was found. The ankle dorsiflexion was weak. In one of the patient of lumbosacral neurogenic neurofibroma, the weakness improved in over 6 months, but not to the level of preoperative power. And in one patient, it failed to recover in case of recurrent lumbosacral schwannoma. Urinary symptoms improved in all 6 patients. And to keep in mind, both the patients of MPNST had complete sensory motor deficit after the surgery because of the radical excision. In follow-up, the follow-up range from 4 months to 5 years, the mean of 19 months. MRI was available in 37 patients, and recurrence was noted in 2 patients at follow-up, one with lumbosacral malignant peripheral nerve sheath tumor and one with neurofibroma. So coming to some of the examples, this is the pre-sacral lumbosacral plexus schwannoma, which was operated via the trans-abdominal approach. So we can see a heterogeneous lesion in front of the sacrum with a good margin around it and a layer between the soft tissue. And on CT scan, we can see the scalloping of the pelvis with a well-defined tumor. So trans-abdominal approach was taken for this patient. Then this is lumbar plexus schwannoma involving L3 root, and retroperitoneal approach was performed for this patient, and the tumor was removed in total excision. This very interesting L4 root schwannoma. In this patient, the internal iliac artery was just anterior to the tumor, so retroperitoneal approach was taken for this patient. And this one of the large tumors, L5 root schwannoma. The tumor was closely related to the rectum. So all these things to be kept in mind, and we should assess this in the preoperative MRI itself. Then the sacral plexus cystic schwannoma. This is one of the cystic schwannoma which was going anteriorly, and L3 root neurofibroma with intraspinal extension. So this is the tumor. Yeah. So going into the intraspinal level. One of the large L4 malignant peripheral nerve sheath tumor, which was approached via the retroperitoneal approach. So we can see a heterogeneous appearance of the tumor, although it is very difficult to differentiate on preoperative MRI. So intraoperatively, this patient has ureteric injury, and we repaired and stenting was done for the patient. Then lumbar plexus L5 root schwannoma. So this is a L5 root schwannoma which was approached by the trans-abdominal approach, and internal iliac artery injury was there in this patient, which was repaired intraoperatively. And this is a lower lumbar plexus tumor which was approached by the retroperitoneal approach. This is the tumor. This is an example of NF1 patient with multiple neurofibromas. Obviously, the treatment was not offered for this patient. This is one of the interesting case of sacral plexus malignant peripheral nerve sheath tumor. So this patient presented with a severe pain in the lower limb with a foot drop, so neurological deficit in a span of 2 months, which is a rapid progression. So MRI scan was done, which showed heterogeneous enhancement of the tumor. Also, we did PET scan, but the PET scan SUV max was only 3, and no major hypermetabolism areas were there. So the preoperative appearance was MPNST, but intraoperatively it looked like a malignant peripheral nerve sheath tumor because it was very much infiltrated into the soft tissue around. And histopathology also was positive for MPNST. And this patient received radiotherapy afterwards after the total excision. And also there was multiple metastasis for which chemotherapy was offered for this patient. Then this is the example of a large lumbar sacral plexus recurrent schwannoma. This patient had torrential bleeding intraoperatively, and patient had disseminated intravascular coagulopathy after the surgery, and 7.5 liter of intraoperative bleeding was there. And postoperatively, we can see radical excision of the tumor. Then this is this is an example of a multiple schwannoma involving L4, L5, S1 roots, and this patient was approached via the retroperitoneal approach. Intrafemoral now intrapelvic schwannoma was noted intraoperatively. This is the preoperative scan. This is the postoperative scan showing complete excision of the tumor. This is again a interesting patient with multiple lumbosacral plexus schwannomas. So schwannomas can sometimes cause hypophosphatemia. That causes demineralization of bone, and pathological fractures can be seen in this patient. So these are the pathological fractures seen on T2 sequence coronal image. These are multiple schwannomas, and these are the tumors removed. So what have we learned? So team work is very much important. Access surgeon and help of our colleagues, the general surgeon, urologist is very much important. Angiography can help in preoperatively in large patients and lumbosacral large tumors. Intraoperative stimulation is strongly recommended. Surgery should be done in patients with progression of the symptoms, and the differential of lumbosacral plexus tumor should be kept in mind whenever we are assessing for the lumbar radiculopathy. And space available for excision is very limited. Therefore, the piecemeal excision should be performed in large tumors. I'm very much thankful to my sir, Dr. Ketan Desai, for because of which I am able to present here, and to the organizers. Thank you so much.
Then, say, in all the cases, you do the tissue biopsy before doing the excision?
17 patients, sir. In 17 patients, because we had a doubt of MPNST, so we went for biopsy, not all patients.
The biopsy you do open, or you have FNAC, some sort of?
So generally, my sir, he sends outside, sir, for to the radiologist. For FNAC, we don't do open biopsies.
You don't do open biopsy?
Yes, sir.
Any other question?
Very often we are missing lumbosacral plexus tumor by neurologist because we are not routinely doing MRI pelvis in toto. We are only prescribing MRI lumbosacral spine. So very often these tumors are we are missing. What about your experience about brachial plexus neurogenic tumors as compared to lumbosacral in your institutes?
Yeah, the vast difference, sir. The brachial plexus tumors are very much common. Lumbosacral are not that common. In my 5 years of tenure, I have seen only 8 patients. The other are SIRS experience. So total 42 patients from KEM Hospital in Hinduja, 2000 to 2023.
Thanks.
Thank you, sir.
Sir, excuse me, sir. Sir, I want not specifically for him, but for entire people and the experts, I wanted a consensus on this tissue biopsy preoperative in these nerve tumors, because yesterday we saw Dr. Ravi Kiran Nalla said that he does not do biopsies preoperatively. He just relies on radiology. So we are having currently mixed opinions on pre-ops. When to do biopsy? Is it really necessary? And third thing is, can we totally rely on radiologically, even medico-legally? That was my question I wanted to ask to all the experts, sir.
See that this radiological differential is only required to exclude an aneurysm or whatever else. Okay, because it will be in contact. All nerves are accompanied by artery and a vein. That's all. Whenever there is a diagnosis of MPNST in mind, better not to do any biopsy, because majority of them are sarcomas. This is the policy we follow. And when you're operating anyway, you do excision biopsy, and then you have to tailor your this thing par of whether you are going to excise the whole of it and then repair the nerve and so on and so forth. If at surgery the what do you call frozen section or whatever you have in your institute says that it is malignant, then you need not to excise the nerve and do the repair, because that is not going to work. Especially in an MPNST, the lifespan is limited. Whatever you do, whether it is occurring in the femoral nerve or axillary nerve or radial nerve and so on and so forth, it will recur and it will metastasize, and majority of them die. We have a huge series, but nobody had made it to the next 1 year itself. Okay. And then I think, you know what, all the papers should have uniform time presentation. You know, not that somebody will be going on presenting and others will have shorter time. Okay.
So we conclude this session. Thank you.
Sorry.
I would like to thank our chairpersons for this session. Thank you very much, sir. Our next session is going to be entrapment neuropathy and other miscellaneous topics. For this session, I would like to call upon our chairpersons, Dr. Puneet Rana, Dr. Lavlesh Rathore, Dr. Charandeep, and Dr. Ashish. Please take the dais, sir.
Hello. Yeah. May I now take the privilege to invite Dr. Dhamika for his presentation on common peroneal nerve injury, multi-stage approach for independent walking.
Yeah, good afternoon, everybody. Yeah, so what causes common peroneal nerve injury? There's largely, these are some of the common ones, such as knee joint dislocation, blunt trauma to the fibular neck area, fibular neck fractures, gunshot injuries and trap gun injuries, tight plaster cast, compartment syndrome, as well as some iatrogenic injuries I have seen following surgery in this region, especially fasciotomy when it's extended for far too high. So why multi-stage plan? Now, at least in our series, many patients present late rather than early. And many injuries are neurologically complex, not just neuropraxia or just axonotmesis, mixed. And many patients default rehabilitation, and they come back after some time. So there is a need for multi-stage plan. Now, and this is also a reason, single stage doesn't work often because incomplete nerve recovery leads to muscle atrophy, and then tendon overstretching, the joint stiffness, and especially ankle as well as the toe joint, metatarsalphalangeal and interphalangeal, and so on. So what is the initial plan? Now, out of this multi-stage plan, there is an initial plan and continuation plan. Initially, I would wait for 3 weeks. In the meantime, electrodiagnostic testing. This is for closed injury. Yeah. Electrodiagnostic testing and occupational therapy is arranged. And a rigid A4 ankle foot orthosis is recommended. And so I reassess at 3 weeks. If there is significant clinical recovery and a trivial injury in the electrodiagnostic test report, NCSC report, I would just continue therapy and convert the the rigid A4 to a semi-rigid one, or a jointed or articulated A4. I will be showing those pictures later. And if there's poor clinical recovery, and any ADT report, as far as I am concerned, is an indication for exploration. Now the weight lies on clinical recovery more than the electrodiagnostic test. And yeah, a rigid A4. So open injury, there's a different initial plan. So naturally, it's explored then and there. Immediate establishment of nerve continuity is the goal, but sometimes you can't do that if there's too much contamination. I defer it for another time. And if there is a mild crush, but in continuity nerve, I would leave it alone, and reassess in a month, because I have found that a lot of them recover, reasonable degree of function and sensation. And the most important step is to ensure good soft tissue and skin cover, and start on a rigid A4, because these are, to be immobilized initially. So rigid A4 is the ideal one to immobilize the nerve repair site and give it a rest. If it's an old injury, clinical assessment as well as electrodiagnosis, be it an old closed injury or an open one. Sometimes they are missed, even open ones, cut injuries. So only the skin is stitched and the patient doesn't mind, and he or she believes it will recover. It doesn't, and the patient comes back after about, say, 3 months or variable period of time. So exploration, decompression, neurolysis is a win-win situation. Like I have found out a lot of the time, these 3 things, even if nerve repair is not possible or not indicated, these 3 things help a lot to recover a lot of function. And rigid or semi-rigid A4 initially. So it's a cascade of A4s. I'll be talking about it later. Yeah, now see, this is the multi-stage plan in one slide. So exploration, as I mentioned, it's both an educational undertaking for the surgeon as well as very important from the point of view of the patient. And decompression and neurolysis, especially for the slightly older cases. And yeah, I was talking about repair. And if repair is not possible, grafting, nerve grafting. And we used to do synthetic nerve grafting conduits as well, but I don't know now. Those days, that was about 10 years ago. So now the type of nerve conduit we used is kind of out of fashion. So we have to wait for the newer versions. And sometimes we can use vein grafts. I don't think it's a very good idea for a bigger nerve like common peroneal. And ankle foot orthosis is mainstay. It comes in different shapes. I will be showing those. And a lot of these people with time get tendoachelis tightness. So it needs to be lengthened, L lengthening or segmental lengthening. Tibialis anterior, extensor hallucis longus, and extensor digitorum plication. In short, it's a shortening. Very useful for partially recovered nerves over the period of time. And there's a thing called reverse transfer of peroneum. I'll be showing on a diagram. Tenodesis of peronei. Because a lot of these people not only have extension problems, they have an inversion issue because of the paralysis of the three peronei. And then tibialis posterior to anterior EHL, ED transfer, both subcutaneous and transmembrane, interosseous membranes transfer. And this is another reverse transfer I will be explaining. And metatarsophalangeal joint fusion. It's indicated in a lot of these people, burnt out cases. Triple arthrodesis, of course, I don't do. I get my orthopedic colleagues to it. See, these are the types of, yeah, so time is running. So I will show these real examples. The last one is a flexible one. The first one is a rigid one. And you see the articulated one as well. So these clinical steps. And here you see peroneus brevis has the best mechanical advantage to my understanding. So it's transected from the myotendinous junction area and taken it back outside the what are those extensor in these restraining all bands and to the tibialis anterior to reinforce the action of eversion. That's a static one. So it's almost like a tenodesis, but I would like to call it a reverse transfer because we are transferring the end of the tendon to a more proximal place instead of to the bone. The tenodesis is to the bone. So key points. Yeah. So low threshold for expression of closed injury and so on. So I won't be reading all this. There's not enough time. You can just read off the screen. Open injuries. There are differences between open and closed. Not enough. Yeah. Main things are the sequence, as I said, rigid, then semi-rigid, then jointed, then flexible. As the functions improve, the tendon functions, you're supposed to go towards flexible end of the spectrum, which gives spring back action that improves the tendon movement more. So little value beyond 6 months and beyond 12 months, expression has almost no value. Then you go for the other stages, as I was talking about. Yeah. So I think this bird has bilateral common peroneal nerve injury. What do you think? No, just joke.
Nice presentation, sir. The floor is open for the questions.
Thank you.
I would like to have this privilege of calling Dr. Abhijit Kohat for the presentation of carpal tunnel syndrome.
Good afternoon. Thank you, chairpersons, and sincere thanks to the organizing committee for organizing such a wonderful event full of great academic contents. And thanks for inviting me. So Dr. Rajesh Sharma has already covered almost all the aspect of the CTS, but still I would try to focus on the diagnostic methods. So we all know that carpal tunnel syndrome is quite prevalent in 1 to 6% of the world population, and symptomatology is mainly depend on the whether variations in the anatomy of the median nerve, and also the activities of the wrist joints. These are the major factor which causes carpal tunnel syndrome, and the symptoms and the prognosis. So the normal pressure is around 2 to 10 millimeter of mercury in the flexor retinaculum where the median nerve lies. But when you do the flexion or the extension causes almost 10 times increase in the pressure, while flexion causes almost 8 times increase in the pressure over the nerves. And this repeated injuries leads to the various sequelae of the nerves. These are the various etiological factors categorized, which increases the volume within the canal, or some alter the contour of the canal, or some deposition. According to that, pregnancy, we commonly see the pregnancy, the hypothyroidism, obesity as a major contributing factor of the carpal tunnel syndrome. And most of the time in a neurology clinic, the carpal tunnel syndrome is the part of the peripheral neuropathies. And with that, we have a different pattern of the sensory involvement. Though the motor involvement is quite dangerous, but the sensory involvement, it gives us the view of the anatomy and the sensory involvement. Now, when we go for the diagnosis of the carpal tunnel syndrome, we have a provocating testing, we have ultrasound, electrodiagnosis, and MRI. As far as the provocating testing is concerned, we have many provocating tests, but commonly we do Tinel test, Durkheim test, Fagduran test, and the phalanx test. So in the Tinel test, we just tap on the nerve, and Durkheim test, we just compress the nerve, we flex the nerve and gives the compression, while the phalanx test, we do flexion of the wrist. The problem with this test is that they are very subjective, it's not objective, and in every clinic we can see that is a different method of performing this test. For example, the phalanx test, on the left diagram, we can see that this is the right way. When we do it, we flex passively the wrist joint, and it causes numbness over the distribution of the median nerve, and we get the diagnosis of the CTS. We see that the median nerve is getting irritated. Similarly, most of the time we ask patient to do it by their own. So in that case, though it's a method of provocation, but it's not very specific for the median nerve, because sometimes it has been seen that even in the thoracic outlet syndrome, it may cause the sensory disturbances over the areas. So there are the limitations. Stent testing, again, stent testing is should be done at the first metacarpophalangeal joint rather than on the distal. Although thinner muscle weakness is a very specific sign of the carpal tunnel. So with this, we can see that this provocating testing, especially tunnel size, has almost 50% of the specificity, and the sensitivity is highest for the Durkheim test. And in the various series, it has been shown that the sensitivity is around 95%. When it's come to the specificity, the thinner atrophy, which is when the nerve damage has already been sets in, and it has damaged a lot. So there is atrophy of the thinner, and it causes median neuropathy rather than carpal tunnel syndrome. It's got in the median neuropathy, full blown. Now we are coming to the electrodiagnostic one. We have decided after the clinical settings that he has a carpal tunnel syndrome. Now we confirm with either ultrasound, the MRI, or the electrodiagnostic testing. So electrodiagnosis are very important, because we have to document that there is a electrodiagnostic abnormalities. They are meaningful, and if the electrodiagnosis is there, how to what extent the nerve has damage. And if there is a electrodiagnostic abnormalities, they are clearly CTS, or is a part of the other neuropathic processes. So what happens when the nerves get damaged? They have two kind of things. Either the myelin will be injured or the axonopathy. So, and sometimes we have the primary myelin involvement or the secondary axonal involvement. Also, when it comes to the pathophysiology of the carpal tunnel syndrome, we have a vascular ischemia. Patient is sleeping in the night, and there is the episodic symptoms that can be contribute to the ischemic area. When we correct the postures, there may be improvement in the symptoms. So repeated this kind of active trauma to the nerves can initially cause the symptomatic conduction block, which can be reversible. When it continues, you have a partial thickness, thinning of the myelin sheet, total thickness, the myelin goes up to the total thickness, the myelin sheet damage, total thickness with internodal in the nodes of ranges are involved, and ultimately leading to the axonopathy. So what happens, sometimes the myelin sheath axonal loss is minimal to the non-consequent node. There will be the slowing of the conduction that lacks the clinical manifestation, or the loss of the myelin at the 2 consecutive nodes of Ranvier. It can cause the symptomatic conduction block. Why it is important? Sometimes what happens, we have a patient with the symptomatic carpal tunnel syndrome, but the NCS is normal. So in that case, is a very minimal damage to the myelin sheath, which is not able to pick up in the nerve conduction studies, but he's symptomatic. He has a carpal tunnel syndrome. Similarly, in axonopathy, there's an acute carpal tunnel syndrome. Patient is lifting heavy weight in the gym and suddenly precipitates the carpal tunnel distribution pain. And we go to the nerve conduction after a certain period of time, and the CMAP we found that is decreased. So what happened? And then what happened? The nerves, the CMAP, it comes back, but that damaged area get remyelination and the conduction slowing is persistent, but the patient is asymptomatic. When axonopathy continues, the trauma, there will be the atrophy and thinning of the muscles. So with these, generally we see the distal latency, as Dr. Rajiv has mentioned that in the previous lecture on the carpal tunnel, that they try to find the distal motor latencies more than 4.4. This is the standard electrodiagnostic criteria. But what happens sometimes, the latencies are normal, but patient is having symptoms of CTS. So other parameters we have to see. That is we always do the median and ulnar. So the motor latencies difference should be more than 1.1. Another is the palm wrist conduction. We have to ask our technician to do the palm wrist conduction, and these are very sensitive methods to detect the subtle CTS. Now, neuromuscular ultrasound. We have another lecture of the neuromuscular ultrasound just next to me. I'm not going to detail. So in the neuromuscular ultrasound, what the radiologist has seen, they generally see the cross-sectional area, and they do it at the pisiform bone level. They get the maximum area there, and the nerve can be localized as the hypoechoic rounded shadow. The normal area is 11 millimeters square. And when there is an enlargement in the nerve size, that's a very objective signs of the nerve edema. And the nerve looks more hypoechoic, and one can have a more the disruption of the fascicle leading to the hypoechoic dots inside. When there is a difference, we are landing the values in the borderline zone, then one can calculate the wrist to forearm ratio. The wrist can be imagine at the level of from the wrist, it can be the 4 to 12 centimeter above, and the normal ratio is around 1.5. Another is the longitudinal imaging view. We can see the course of the nerves, whether they are the thickened, where they are the swollen, and the dynamic stress testing, where the one can see at what level it's getting compromised. Dynamic stress can be done with the ball to the hands, and the ultrasound can be performed while he's compressing the ball. So overall specificity and sensitivity is 60 to 80% in the case of the neuromuscular ultrasound. Similarly, MRI has a various parameters, including the flattened ratio, circumferential surface areas, and all these parameters can be seen. And these parameters, including the cross surface area and at the tunnel inlet, is almost 80 to 100% sensitive. So what when we are comparing these methods? So again, I'm going to the same. There are the question is the median nerve is entrapped at the wrist. Okay, fine. Where are the nerve lesion is located? What are the mechanism? What are the nerve with the single nerve lesion is a part of the neuropathy. All right. So when it's come to the ultrasound ADX, it's the yesterday's lecture. This is a very good slide. USG and ultrasound, one shows the anatomical and other shows the functional. Electrodiagnosis cannot show the anatomical. So for the first questions, USG entrapped at the wrist, but other question cannot be answered whether by the MRI or by the ultrasound. So in certain situations, electrodiagnosis is important, but in certain situation, ultrasound and the MRI is also important. So similarly, there are various studies. I'm not going one by one, but this is a very good paper where it's very well mentioned that USG has a very good sensitivity specificity, but still it cannot replace the electrodiagnosis as the first line of therapy. Similarly, this slide where we can have a various combination of the in the CTS, where there is the ultrasound and the electrophysiology. All right. So in that case, clinical plus electrophysiology is more useful than the imaging studies. So the gold standard is carpal tunnel syndrome. Yeah. So even the MRI is having moderate evidence. That's for the routine screening of the CTS according to 2019 the guidelines. As far as the medical management is concerned, immobilization and carpal tunnel steroid has a better evidences compared to early surgeries. The limitation with the injection is that you cannot inject it repeatedly because it leads to the scarring of the tissues inside the canal, leading to the again patient landing into problem and requiring the surgeries. So if the injections for 2 or 3 injection patient is not responding, better to go for the surgeries. So I would like to conclude that the clinical examination followed by the electrodiagnosis is the gold standard. In certain situation, MRI and ultrasound can add to the diagnosis and cannot be, at least MRI cannot be used routinely for the screening of the carpal tunnel syndrome because of the cost issues and require a lot of expertise in the interpretation. And immobilization is the first line treatment in the carpal tunnel. Thank you. So it's all happy Lori and Makar Sankranti and Pongal and Bihu. Thank you so much.
Presentation, Dr. Abhijit. The floor is open for the questions. Thank you, sir.
Yeah, I have a question.
Okay, yeah.
Hi, I will just repeat the question that I asked Rajiv from your point of view.
Yeah.
If you're clinically sure that it's carpal tunnel syndrome, but electrophysiology is normal.
Okay.
Would you repeat it or would you straight away say, I don't need further confirmation, go ahead with surgery?
All right. So what happened? That's an excellent question. So that's what I was asking Raju. Actually, what happened when you see the number of the patients, they complain of pain over the wrist, something which is not in the distribution of carpal tunnel. So there are the two possibilities. There is some pain and you are going for the NCS and you are getting some changes, okay, or some distribution in the carpal tunnel area. Now, what I have the specific sensitivity I have shown here for this clinical parameters. These parameters are equally specific and sensitive in tenosynovitis, mild tenosynovitis of the joint. So when you are interpreting the only clinical signs, then you should be very careful because what is happening, for example, you are going for a surgery. For mild cases, you are not going to operate. All right. So when you are going for the surgery in the milder stage, I don't think anybody is going to operate the milder stage. In that case, nerve conduction may be normal. In that case, I will manage the patient conservatively. When it's come to the surgery, you are going for the moderate to severe CTS. Till that time, there should be some changes in a nerve conduction. It's literally unusual to have a moderate to severe changes, moderate to severe CTS, and the NCS is normal. In that case, I will look for some other pathology at the local site. For mild, nerve conduction may be normal, but I'm not going to operate that. I'll manage it conservatively.
So you mean to say in a moderate to severe carpal tunnel syndrome, electrodiagnostic, there will be some finding?
Yes, there will be some finding, definitely.
Any more questions, please? Thank you, sir.
Thank you.
I would like to call upon the next presenter, Dr. Kanan Karupaya Kumar. He is giving the presentation of use of ultrasound in the carpal tunnel syndrome.
little difficulty. Maybe we can have the next presentation and then I can come back. That will be easier. Yeah.
In that case, we would like to call the next presenter, Dr. Suvarna Sukriya. She is presenting about leprosy and neuropathy.
Thank you. Respected chairpersons and one and all present here, very good afternoon. I express my sincere gratitude to the organizing team for giving me this opportunity. So let's start the discussion for today. It's leprosy and neuropathy. So as we all know, leprosy is very endemic in India. It's not only India, it's the entire Southeast Asia region, which contributes to around 72% of the global leprosy burden. The current prevalence rate in India is 4.5 per 1 lakh population. This was in year 2021 to 2022. And we are heading towards leprosy eradication by the year 2027. So I have brought few cases of neuropathy associated with leprosy who attended the neurology department in the past 1 year. So the first patient, we have a 32-year-old male who presented with numbness over left hand followed by weakness of 7 months duration. So as you can see, the examination, there is a claw hand in the left side. Along with that, there are some healed, dry skin lesions also. So further examination revealed enlarged peripheral nerve trunks. Along with that, he had hypoanesthetic skin lesions. So he underwent a slit skin smear, which was positive. So the presence of hypoanesthetic patch, an enlarged peripheral nerve, and a positive slit skin smear clinches the diagnosis of leprosy. So this was a mononeuropathy, which is affecting the left ulnar. So which is the most common presentation of leprosy and neuropathy. So other peripheral nerves which are commonly involved in leprosy are median, followed by posterior auricular, and the other peripheral nerves which I have listed out. So he underwent an NCS, a nerve conduction study, which showed a reduced amplitude, CMAP amplitude in the left ulnar nerve. Other than that, we can also see that the snaps were absent in all the peripheral nerves. So this was a subclinical sensory neuropathy also, though he presented with a mononeuropathy. So he started on MDT, and then his sensory symptoms had improved. Moving on to the next case, we have a 37-year-old male who presented with paresthesia involving bilateral hands and feet for 1 year duration. So examination, we found that he had reduced touch and pain in bilateral hands below the wrist and bilateral feet below the ankle. Other than that, he didn't have any skin lesions. So on detailed examination, we found this nodular lesions in his earlobe. And on exposing him, we also found a thickened greater auricular nerve. So detailed clinical examination will always give us a clue for the diagnosis of peripheral neuropathy. So he underwent a nerve conduction study, which showed reduced absent CMAP in bilateral peroneal, and there was also sensory involvement. So this was a case of polyneuropathy, which was distal symmetric involvement. Only small fiber involvement he had come with. Large fiber involvement is less likely in case of distal symmetric polyneuropathy in leprosy, and they are usually prone for ulceration and deformity. Moving on to the third case, we have a 27-year-old male who presented with erythematous skin lesions over anterior aspect of bilateral legs of 1 month duration associated with paresthesia involving left foot followed by right foot for 3 weeks. So these are the erythematous indurated skin lesions in the bilateral anterior aspect of the leg. So he underwent a nerve conduction study which showed absent CMAP in left tibial and bilateral peroneal nerves and absent snaps in both sural and superficial nerves. As we can see here, there is some asymmetrical involvement, so which was pointing towards a mononeuritis multiplex picture of involvement. So wherein we get an asymmetrical, asynchronous sensory motor involvement. Usually in mononeuritis multiplex, more than 2 or more peripheral nerves, non-contiguous sites are involved. It is most commonly seen in tuberculoid spectrum of disease. Ulnar nerve and common peroneal nerve being the common nerves which are involved in mononeuritis multiplex. Many a times, like a patient with mononeuritis multiplex, by the time they come to us, this asymmetricity might have gone because the peripheral nerve involvement, it becomes more coalesced and it will come to us with a more or less asymmetrical pattern of involvement. So the history will help us in determining whether it was an asymmetrical to start with or it was symmetrical to start with. So moving on to the case 4, we have a 42-year-old male who came with paresthesia involving the left upper limb followed by right upper limb and bilateral lower limbs for 2 months duration. Examination revealed a thickened bilateral ulnar nerve and he had a brisk deep tendon reflexes. Other than that, we did not find any cutaneous lesions. So he underwent a nerve conduction study which showed predominant lower limb involvement, sensory motor. And his ESR was 50, which was on the higher side. We wanted to rule out a vasculitis, which was negative. His slit skin smear was negative. However, he underwent a nerve biopsy, which showed these epithelioid granulomas and which were staining acid fast. This bacilli was acid fast bacilli in the fight stain. So this was a pure neuritic leprosy, which presented with sensory symptoms in the absence of cutaneous manifestations. He was started on MDT along with corticosteroids, following which his sensory symptoms had improved. So pure neuritic leprosy contributes to 4 to 18% of the leprosy cases. For some unknown reasons, it is more prevalent in southern part of India, and young males are commonly affected. And usually it is a mononeuritic pattern with upper limb predominant involvement. So moving on to case 5, we had a 33-year-old female who presented with numbness involving bilateral hands and feet. Other than that, the examination, it was showing a dry, shiny skin with loss of skin appendages, and she had a distal symmetric sensory involvement. So as we can see in the pic, there was a shiny skin with loss of appendicular skin appendages. So this points towards involvement of the small myelinated, that is autonomic neuropathy, which is most commonly seen in multibacillary leprosy, and it is usually regional. Regional in the sense, I mean, it is limited to the involvement to the limbs only, to the extremities, whereas widespread dysautonomia involving cardiac as well as respiratory involvement has also been reported in leprosy. So the common neuropathy associated with leprosy are mononeuritis multiplex, and polyneuropathy, which is distal symmetric, sensory, and motor. Other than that, pure neuritis and autonomic neuropathy, which I mean isolated autonomic neuropathy and isolated cranial neuropathy. In isolated cranial neuropathy, usually trigeminal nerve and facial nerve are commonly affected. Other than that, there is an entity called leprosy ganglionitis, where the patient will present with sensory ataxia, pseudoathetosis, which are also reported from our part of the country. So moving on to case 6, we have a 48-year-old female who was a diagnosed case of Hansen's, who was started on MDT. Few months starting MDT, she developed new onset subcutaneous swelling involving her face and forearm, associated with increased paresthesia involving bilateral hands and feet. So as I have shown in the pic, there are some nodular skin lesions in the extremity as well as in the face. So this was a case of lepra reaction associated with neuritis. Since she developed after starting MDT and there were new lesions, this was most likely a lepra type 2 reaction. So she was started on steroids, following which she showed some improvement in neuritis as well as in the swellings. So one common complication in neuropathy associated with leprosy is nerve abscess, which is seen in around 1.3% of patients with leprosy. Usually children and adolescents are most commonly affected, maybe because of the poor immunological status, and it is usually seen in paucibacillary spectrum of disease, with ulnar nerve bearing the brunt of the disease, followed by posterior auricular, peroneal, and posterior tibial nerve. The pathogenesis of nerve abscess in leprosy being the bacterial colonization of the nerve, leading to granuloma formation, caseous necrosis, and there is a cold abscess. Many times patients respond to conservative management with MDT and with short course of steroids, whereas in some cases they do require this exploration and pus drainage. So the management as per WHO, it is depending on paucibacillary and multibacillary, 6 months and 12 months triple drug regimen of dapsone, rifampicin, and clofazimine. And corticosteroids 0.5 milligram to 1 milligram per kg body weight is required, which is usually given for a period of 3 months and then tapered over a period of 6 months. So to conclude, leprosy is endemic in India. Prompt clinical examination will give us the cause of peripheral neuropathy. Many patients of peripheral neuropathy, we don't get a cause. So detailed examination, we usually get a cause for peripheral neuropathy. Appropriate diagnosis and timely initiation of MDT will help in reduction of disabilities. Thank you.
The floor will be open for the questions now. Any questions, please?
Nice presentation. So I consider the leprosy is the disease of the neurologist. The leprosy is a neurological disorder which has a skin manifestation rather than a skin disease having a neurological manifestations. Okay. So problem is that when it's come to the treatment, it's a 6 month and a 12 months. Okay, and the leprosy, the treatment is served by the leprosy eradication program. All right. So you really think that 6 month and the 12th month treatment is good enough, and after that, when is the pure neurotic form of the leprosy, which would require a very longer treatment, like so tuberculosis. Okay, there is always a dilemma. So the eradication program, people they say they don't serve the patient. All right. So what is your comment on that? The duration of the treatment, is it okay 6 to 12 months? I'm sure you have used it for more than that.
Sir, actually, many a times in differentiating whether it is possibacillary and multibacillary, the mistake lies there. Many times the patient are diagnosed as possibacillary and they are started on 6 months treatment, whereas ideally it was a multibacillary case and it needed a long-term treatment. So I think the diagnosis or the differentiation as possy and multi, that should be very definite. If it is definite, then with appropriate timely treatment, I think it is sufficient. They improve usually.
Any more questions, please? Nice presentation, ma'am.
Thank you, sir. Thank you.
Yeah, thank you, and sorry for the technical difficulties. My name is Dr. Kannan. I'm an orthopedic hand surgeon. So based out of Bangalore. First of all, I would like to thank the organizers for inviting me here. And today, the topic I've taken up is the use of ultrasound in OPD for carpal tunnel, diagnosis and management. The important thing here is the management as well. I would politely decline with my, differ with my previous two speakers who were saying that the electrodiagnostic tests are better than other tests. So my job today is in the short 10 minutes to make you aware of the fact that ultrasound can be used by clinicians rather than radiologists, and we can effectively manage carpal tunnel syndrome in a much better way compared to blind injections and surgeries. So if it piques your interest and if it makes you think about ultrasound, my job is done today. So a lot has been spoken about carpal tunnel anatomy and the syndrome, so I won't go into the details. My only thing here is to reinforce that it's a clinical diagnosis, which my previous speaker has made it very clear. And for me as a hand surgeon or as a surgeon who's going to do it, the EMG NCV adds to the confusion because there is a huge amount of inter and intra-observer variability. If you are the clinician who's doing the EMG and NCV study, it makes sense because you're reproducing the test on a regular basis and you're confident about your own skills and you do it on a regular basis. But if most patients who come into the OPD come in with an EMG and NCV study, and therefore there's a huge inter and intra-observer variability with it. So here is the role of ultrasound. Right, there are various papers which show the sensitivity and specificity of the Fallon's test, Tinel's test, and NCV and EMG as well. See, the NCV basically, as Sarah said, it is about 4.5 millisecond. Anything beyond that latency period of motor latency is indicative of carpal tunnel syndrome. So the multiple papers which have shown in at least in hand surgery literature, upper limb literature, that electrodiagnostic grading and carpal tunnel release outcomes do not match. Electrodiagnostic grading and carpal tunnel diagnosis itself do not match. So therefore, there is a huge amount of literature if you look on the hand surgery or upper limb surgery where the electrodiagnostic tests are not good indicators of carpal tunnel syndrome and their management. So coming to the sensitivity and the specificity, the most sensitive and specific test is actually the CTS-6 questionnaire, which is commonly used in the American and the Western literature. Unfortunately, this is not reproducible in the Indian scenario because of the vernacular and the language issues. So, but the CTS-6 has been shown to have the highest specificity and sensitivity. It's a bunch of 6 questions which the patient answers. For example, night symptoms, which is more specific and sensitive than anything else. And NCV EMG, if done by the right person, the right electrophysiologist, and done repeatedly over a period of time. For example, you have to do about 50 to 100 of these every year to be able to reach sensitivity and specificity of 91 and 83%. And ultrasound has been shown, if not better, has been shown to be equivalent to CTS-6 and your electrodiagnostic tests. And it is an easily learnable skill, right? So most surgeons in the West are doing ultrasound and managing this carpal tunnel, and this is easily incorporatable with a couple of issues in our scenario as well. So what do we need for carpal tunnel syndrome diagnosis? We need a test which helps with the diagnosis, which is not available right now. It is not painful. If any one of us have undergone the nerve conduction and EMG test, we know that how painful it can be. It should be easy to do and reproducible and readily available. So once you see a carpal tunnel syndrome in your OPD, you have to send them back for a diagnostic test, get them back. It takes a few days or a week even maybe, and it should guide with treatment. So what are the advantages of ultrasound in your OPD? It's non-invasive. It's absolutely safe. The patient does not flinch, and it's very quick. If you do it the right way, it takes about a minute or 2 minutes to do the diagnosis of carpal tunnel syndrome with ultrasound. There's reduced cost and turnover time, and occasionally you can identify other median nerve pathologies. So over a period of time, as we get experience with it, it can take over the role of MRI and pick up other pathologies in the wrist as well. And you can treat along with the diagnosis as well. So what are some of problems with the ultrasound? It is user dependent. And the Indian scenario, we have the PCDT Act. So therefore, you have to get your name registered in the, if you're doing ultrasound guided injections and imaging. The learning curve is not as steep as most procedures. So within the first 5 to 10 cases, we can pick up and start doing this ultrasound. The cost of the machine is there, but it's coming down. We don't need a fancy machine. We can have handheld ultrasound machines which are about $1 lakh or 2. And you need a second person's assistance when you're managing these or giving injections. Right, so coming to the technique, this is the ultrasound machine that we are using right now. It's a high-end machine used by the radiologist. I've added my name to it for the act. And we are using a probe, such a probe, but we do have a smaller hockey stick probe, which is even smaller, has a smaller footprint and give you better pictures. So you have to make the patient sit on a cot with a pillow under both the hands, and both the hands, the volar aspect of both the hands and the wrists are exposed so that you can compare and contrast between the two sides. Now coming to the anatomy and how you see these structures. This is a CT scan, an axial cut of the CT scan at the level of the wrist. We can see the pisiform bone and scaphoid bone. So for a single shot, single procedure diagnosis of ultrasound, you have to get this view where you get the scaphoid and the pisiform on an axial cut. So that is called as a short axis in ultrasonography, verbology. In their terms, they call it the short axis, but it's actually an axial cut of the wrist. This is a long axis anatomy, or the sagittal cut, where you see distally is the carpal bones. Distally is the carpal bones. There's a lunate, there's a capitate. This is the radius, above which you would see the pronator quadratus here, and here the flexor tendons along with the median nerve. So these are the two directions in which you see the ultrasound of the wrist. So one is a short axis, which is the axial cut, and the long axis, which is the sagittal cut. Now coming to the short axis, where you place the transducer in a transverse fashion at the wrist. And here you can see all the structures. Basically, ultrasound does not pass through bone. So once the waves stop passing through the bone, stop passing through, that is bone. So this is basically the scaphoid. You can see on the left-hand side. On the right-hand side is the pisiform. This is where you have to measure the median nerve cross-sectional area. And in the carpal tunnel, we can see the flexor pollicis longus, 4 profundus tendons, 4 superficialis. This is the median nerve here. And above it, these arrows mark the flexor retinaculum. You can also see the ulnar artery and vessels here. Now, this is the long axis. So the previous one was the short axis where the transducer is placed transverse on the wrist. This is a long axis where the transducer is placed longitudinally, giving us a sagittal cut. So if you can see below, here is the carpal bones. Sorry, here is the distal radius, here is the carpal bones, and here is the metacarpal. So here we can see the flexor tendons, and here you can see the median nerve. So you can see the median nerve bulged out here, compressed here, and if you go more distally, again opens up. So this is a hourglass constriction of the median nerve, which is typically seen in the carpal tunnel syndrome. Now again, an image to reiterate the structures. The scaphoid is seen on the left side, pisiform on the right, flexor tendons, flexor retinaculum, and the median nerve in the center. So what are the diagnostic ultrasound measurements? As my previous speaker clearly told, there are multiple measurements you can take. But the one thing that we can do as surgeons in our OPD is the cross-sectional area. Just one cross-sectional area measurement of the median nerve gives us a good indication of whether the patient has a carpal tunnel or not. So basically, we use a mouse-like structure on the ultrasound machine, and you trace out the median nerve, and the machine spits out area, cross-sectional area. So that gives us a good indication whether the patient has carpal tunnel or not. The other features that you can measure are flattening ratio, difference between the cross-sectional area between proximally and distally, the bowing of the flexor retinaculum, and other things. These are for ultrasonologists who can give us a better detailed picture. But for diagnosis and management, the cross-sectional area is sufficient to get an idea. So if you can see here, the median nerve is flattened out, where the length is more than 3 times the breadth, which is a good indication of compression of the median nerve. But we are not going to use this in our day-to-day practice. So this has been validated in multiple studies. Of course, this is on the other side of the literature, that is plastic and hand literature. So this was the first study in 1992, which compared the EMG, MRI, and ultrasound, and found that there is very good evidence for the use of ultrasound. And this is the hourglass constriction type of picture, which you can see in most carpal tunnel syndromes. This is where the flexor retinaculum compresses the median nerve. Can I just take 1 minute time? So the proximal end is ballooned up, and the distal is ballooned. So this is very clearly seen in the ultrasound machine. So coming to the cross-sectional area, anything more than 10 millimeters square is indicative of carpal tunnel syndrome. There are no two ways about it. This has been shown at least with 90 to 95% sensitivity and specificity. And very severe carpal tunnel syndrome has an area of about 16 millimeters square. The other pathologies that you can make out with this median nerve is a bifid nerve, with you can see a persistent median artery in between 2 median nerve branches. And you can also make out tumors. This is a median nerve. In between, you have a schwannoma type of tumor with flexor digitorum tendons in the bottom. So this is how we manage these injections in the OPD. So here is what we call as a hydrodissection or an injection. If you can see, the needle is coming towards the bottom of the median nerve, pushing in fluid and floating the median nerve above from the flexor tendons. And we do the same thing, separating the tendon from the flexor retinaculum as well. So here we are separating the median nerve from the flexor retinaculum. You can see the median nerve bouncing like a ball, fluid all around it. So this is called as hydrodissection, and this is equivalent to actually doing surgery in many cases. So just to replay the video, so we're pushing in fluid both from the bottom and the top. And the fluid that is usually it's about 1 cc of lignocaine and 1 cc of steroid injection. So in our experience, we have been able to incorporate this in the last year or so. We have done this on 22 patients, and our average cross-sectional area has been 14 millimeters square. That is more than 10 is carpal tunnel syndrome. Our results, we have still not compared. We either think it is equivalent or better, but what are the advantages? It's easy. We are able to diagnose on the spot. We don't need an electrodiagnostic test. And in the future, ultrasound can guide us with carpal tunnel release as well. Thank you. Thank you very much.
Very nice presentation, doctor. Any questions, please?
Yeah, a nice presentation. I had a couple of questions.
Yeah.
So when you showed that you inject lignocaine plus triamcinolone, this itself you say benefits the patient so they can avoid surgery.
Yeah, that was an off-the-cuff remark. I would no evidence for it. Yes.
Yes.
Yeah.
So the relief is immediate in those cases?
So actually, sir, what happens with steroid injection, blind steroid injection, is they're going to get worse for a couple of days because you've pushed in fluid. So they're going to have a lot of pain for 2-3 days. So they have to take some NSAIDs and right. So my experience is the average time taken for the symptoms to relieve is 7 to 14 days from the time of a blind injection.
Right.
Which is going to be the same with the help of an ultrasound as well. Yes, sir.
And the duration of relief?
So this is we have done it for a year or so.
Okay.
Yeah, but they have good relief. They are equivalent to blind injection, right? Yes, sir.
And the second question is, if you are operating like open surgery or endoscopic surgery for carpal tunnel release, have you used ultrasound pre and immediate post-op to see if there is improvement in the nerve cross-sectional area or to make sure that everything is decompressed?
I haven't done it, but we have done for all the carpal tunnel releases because we have an ultrasound machine in the OT because the anesthetists use that. We use the same machine. We check pre-op. Post-op, we are not doing it immediately. But studies have shown, there are multiple studies on this, which have shown that there is no change in the cross-sectional area.
Okay.
Pre-op and post-op. And people have not been able to explain it, but patients have relief of symptoms. So this cross-sectional area that has happened compressed is not going to change post-op.
Okay.
Yes.
Understood. So, but it might change over time, over 6 months, 1 year.
No, studies have shown
that
over
time also.
Yes, it does not change, sir.
The final comment is, or a question is, instead of lignocaine and this triamcinolone, can we use hyaluronic acid plus triamcinolone or something like that? Have you thought about it?
So hydrodissection is a term that sonologists use. People have used various different materials. People have used 5% dextrose. People have used normal saline. People have used lignocaine. People have used, I've not heard of hyaluronic acid. My thinking would be that hyaluronic acid may be a problem because it doesn't get absorbed very easily. So it is going to cause mass effect for much longer. And so you need to inject something that gets absorbed within a few days because otherwise the patient is going to have worsening of symptoms. Yeah.
Yeah, the only reason hyaluronic acid is because it's used commonly for other synovial filled spaces. It might cause lubrication and we don't know the exact pathophysiology behind all this, and especially in carpal tunnel.
Yes, correct. I agree with you, sir. Yes. Yes. Thank you.
Sir, my personal question to you and the other seniors is, can we do the surgery? Can we make the decision about the surgery of carpal tunnel syndrome if we are having absolute diagnosis by the clinical examination? And if we are having this level of the ultrasonologist, 91 and 94% sensitivity and specificity, and not be doing the nerve conduction velocity, because that is,
I agree. I think ultrasound is coming up. We also do a lot of ultrasound, and ultrasound is the future. I think every surgeon should be knowing about it, and I'm totally for it. Electrodiagnostic studies take time to happen, and obviously they are not in your hand. It's a different set of specialists doing it. So if we can replicate it, nothing more than.
Thank you, sir.
I have one question, sir. If you allow, I have one question. I was a bit surprised by you saying that there is temporary worsening after the blocks. I mean, in our clinical scenario, we are often putting the blocks before the surgery, and it helps in doubtful cases also. Suppose patient has cervical problem also, or you have some problems. So we apply blocks, and in fact, after the blocks, there is improvement of pain as well as motor power also in some cases.
No, I think you misunderstood me. I'm not saying worsening of symptoms. Patient has pain because of the injection itself for the first few days, sir. And the symptoms disappear. If you're talking about the steroid effect, it takes about 7 days. It does not happen the first or second day, sir. Blocks is lignocaine effect. If the patient is we have injected about a cc of lignocaine, that is going to improve symptoms for an hour or so. That's all. But the steroid effect takes about 7 to 14 days.
We apply bupivacaine, so it gives a longer time
I agree,
relief.
yeah.
Second thing, I want to know, for the licensing purpose, can we register on ourselves, or we have to collaborate with the radiologists every time?
No, you can register on yourself. You can do it. We have hand surgeons in India already, about 4 or 5 of them who are doing it and who have taken a license on. So the licensing is not restricted for sonologists or radiologists alone. So what happens in an institution is that we have an institutional license. So you just have to get your name added to it, right? So when we did initially, I never knew this. So then somebody came from that, you can't do this because this is a serious problem in India. Because in the US, they don't have to have any license to do this. So we added my name to the institutional license. So we have anesthetists in every hospital who use one single machine. So 10 of them use it to give the blocks. So you just have to add your name to it, sir.
Thank you, sir.
So I wanted to answer your question. See, the thing is, you should hear him clearly. He is saying that he is injecting the solution into the carpal tunnel inside. Already it is tight, and you are introducing some more fluid. Therefore, there is likely to be pain. That pain is, again, what he is telling right now. Yeah, that it is not due to injection. It is due to the contents. You have increased the contents. And what you are asking is that you are giving local block. Local block or local infiltration is different from hydrodissection, which is described. You understand? And I wanted to know who are these? Did you tell us the details of the patients into whom you have injected?
I haven't, madam. Because of time constraints, I thought it would be a.
No, it's not time constraints. We want to know why did they opt for this injection rather than for surgery? Surgery is a simpler procedure, I think, and it is much more.
I understand, madam. So in our protocol, I mean, what we always give couple of injections. So even before incorporating ultrasound.
So do you take consent for that? I will do the ultrasound imaging, and I also will inject into the carpal tunnel. Do you take consent like
We
that?
are not taking, no.
Or you do it just like that? And
No.
then
I mean,
say-
it is it costs money. The other thing is that they are charging, the hospital is charging for the ultrasound, just like they're charging for a diagnostic ultrasound, which I've not been able to convince them. So the cost is involved, a couple of ₹1,000. So I talked to them, and if they are ready for an ultrasound guided injection, but we don't have a specific consent for it right now.
No, you should have, no?
Okay.
You should have. Because, see, you are telling that you're going to be injecting into the carpal tunnel. And then how do we know that you are, that one point of the needle is not going into the nerve? And on one hand, we are talking about injection pulses and all. And injection pulses, as you know,
I understand.
Are at various levels of injection. So I don't think that this is, say, technology should be there. We should improve, but we should also know how to use it for the patient's good as well. Because ultimately it is the patient who matters.
Yes.
Correct?
Yes.
You please think about it.
Yes. Thank you, madam.
Thank you, sir.
Can I ask one? Just last. Yeah. So every diagnostic modality has its own limitation. So 2 comments. Symptomatic CTS, but ultrasound negative. Have seen that it happens.
So it's close to 95, 91, 95% sensitivity specificity. I'm too early in the ultrasound field to be able to comment on that. But it's very unusual is what the literature says with ultrasound, because you have other modalities. Like if you can't find a static cross-sectional change in the area, then you have dynamic. That means you, as you said, sir, you use a ball, make the patient flex and extend, check how much is in flexion, how much in extension, if there's a difference of 2 to 3 millimeters square. So those are advanced sonological techniques, which as surgeons will take long time for us to learn. And if you give me the scenario where ultrasound negative and still clinically, I would give a diagnostic injection and see how the patient does. That's what I would approach as a surgeon. Yes, sir. Yeah.
And another thing, we have a in a good discussion with the radiologist. Actually, with sonography, as you said, it's you can do it one. But our expert radiologist, the neurologist, says the specificity and sensitivity detecting the nerve area is false when you change the probe. So you require a better probe to see the good shape of the nerve rather than what you are using in the abdominal USG or something like that. What's your comment?
I completely agree. The probe that I showed you is an abdominal probe. It is an abdominal probe. You need something called as a hockey stick probe to focus on small joints, including the wrist and fingers for trigger fingers and everything. But if you are at the right spot that is, if you see the pisiform and scaphoid, and that is the area where you have to measure the median nerve. So you won't miss it. So you have to look for the scaphoid and pisiform and measure the nerve at that point. So that is the exact location where you have to measure it. Of course, this probe is not ideal. Some hospitals and some institutions have called the hockey stick probe. That is the ideal probe for it. So, yes.
Thank you so
Thank
much.
you.
I would like to call the session closed.
Thank you very much, sir, for this beautiful session. We will now proceed with our valedictory function.
I would like to invite Honorary President Dr. B. Indira Devi and Dr. Deepak Agarwal, Secretary of ISPNS, to the stage for distributing prizes of paper and poster presentation. Also, Dr. K.K. Bhoi, Sir, Secretary of Chhattisgarh Association of Neuroscientists, on stage to give away the prizes. I would also like to request Dr. Anil Sharma, Sir, to kindly come on stage to distribute the prizes. Best Paper Award, first prize goes to Dr. D. Abhi Sindhuja. Second prize, Dr. Anuj Tiwari. Second prize, Dr. Anuj Tiwari. For poster presentation, first prize goes to Dr. Chirag Jain. Dr. Chirag Jain is currently not present here. So on behalf of him, ma'am. Second prize goes to Dr. Abbas Muyadi. Thank you, sir and ma'am, for
So I think it was a very nicely organized conference. I need to thank Dr. Anil, Dr. Shamender and the team for organizing such a lavish academic feast. And I think we all benefited from it. And I thank Madam also, who the outgoing president, and who has supervised everything from start to finish to make it a very unbiased and nice conference. So thank you all for this beautiful thing. We all enjoyed.
Good afternoon, respected teachers, faculties, and dear colleagues. Now we have come to end of this fantastic academic gathering. On day first, our academic program was in schedule and it ran very smoothly with the help of all of you. On day two, we have some glitches as there was many cancellations of the flight and faculties rescheduled their itinerary. First of all, I thank Dr. Anil Kumar Sharma for involving me to organize this conference. We are very grateful to our Chhattisgarh Association of Neuroscientist Faculties and faculties of Plastic Surgery of Chhattisgarh who helped us to organize this conference very smoothly. We are very much thankful to our most important helping hands, the Get Set event organizer, Vinodji, Prakashji and Gaurav, plastic surgery and neurosurgery residents, Abhi Aparajita, Jalat, Abhijit, Mayank and Abbas, Bhupeshji, Dushyant, Rocky, and our valuable sponsors. Also, we are thankful to our audiovisual team and the attendants of this hall who have worked very hard to make this conference successful. We are also thankful to the faculties of anatomy department who helped us to organize the cadaveric workshop on day one. We hope your stay was pleasant in Raipur for the hospitality which we were able to provide you. Please pardon us if there were any lapses. Now I will conclude my speech. We wish you all have a safe and pleasant journey back to home, and we hope to meet all of you soon in next meeting. Thank you again. Now all of us can proceed for lunch.
Before that, can I make some comments? Hello. Now, really, I want to congratulate the whole team, Dr. Anil and his colleagues, Dr. Sumit, and definitely Dr. Deepak and Dr. Indra Ma'am, for organizing this very good scientific feast where we had the cadaveric dissections, operative, then various papers, and the love and affection which was given with a very good ambience. आज यहाँ से जाते समय ऐसे लग रहा है कि दुल्हन अपना घर छोड़कर जा रही है. नमस्कार. Thank you.
Thank you.
सर कंबाइन फोटो एक स्टेज एक फोटोग्राफ होना चाहिए.
Please rise up for the Jana Gana Mana.
गण मन विनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंग विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा तब शुभ नामे जागे तब शुभ आशीष मांगे गाय तब जय गाता जन गण मंगल नायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
एक फोटोग्राफ
Please come on the stage for group photo.
Youngsters can come down. Yeah, that looks very nice.